Good morning, guys. Actually, wait. Yeah, it's afternoon. Never mind. Anyways, good afternoon. I'm Ahmed Maklad, and today, inshallah, I'll be talking to you guys about 3 of your 5 lectures, and Haroon will come after me and discuss the MRI and the ultrasound. Let's wait for 5 more minutes for people to start joining, and then we can start. All right. Also, can you guys hear me? Just say in the chat or something. Great, perfect. All right, we'll just wait for 5 minutes then. All right, I don't see a lot of people joining, kind of slowed down, so I guess we can start now. All right, so let's start, I guess. So I'm going to start with the CT scan, inshallah, right, and the clinical application of CT scans, and then I'll move on to the PET scans, which I dread, by the way, and then we're going to finish this and talk more about contrast material and contrast. All right, so let's start. So please, guys, by the way, if you have any questions, if you feel that I'm going too fast, because sometimes I do, just let me know in the chat and I'll slow down or answer any of your questions. All right, but please let me know. Anyways, so we're going to talk about the CT scans, as I mentioned. All right, so this is our first slide, and I hope you guys remember your physics lecture about CT. Haroon gave it to you last time. I gave it last year. So yeah, this basically just tells you that different material in your body is going to absorb different amounts of Hounsfield units of rays in a CT scan. So basically, air is going to be the darkest, and metal is going to be the brightest, and then everything in between is just a spectrum. All right. So keep that in mind. Can I switch to a laser or something? Yeah, there we go. That's better. All right, so keep that in mind. Now, when do we use CT scans? Remember, CT scans are not as, they are much better than X-rays in that they give you a 3D image. They give you a higher resolution and a better quality image, basically, all right? So you can use CT scans when X-rays are not showing you enough, all right? You can use CT scans in acute conditions and in non-acute conditions. What I learned is that it's more widely used in acute conditions. So in the ER and in collision accidents, car accidents, motorbike accidents, CT protocol is usually used then when you want to discuss radiology and whatnot. All right, so you can use CT scans to visualize the abdominal organs. All right, this could be non-acute, acute. Either ways you can use them. All right, As mentioned on the slide, you can use them in acute abdomen where you don't know what's going on. You think it's appendicitis, you don't think it's appendicitis, something else, you're not sure, you can use a CT scan, all right? It's very helpful in kidney stones because not all kidney stones will be detected using x-rays because not all kidney stones are radio opaque. They're not all made of calcium, which is bright. Some of them are made of, for example, uric acid, and uric acid is radiolucent. So yeah, you can use CT scans for kidney stones, for appendicitis, for perforation, obstruction. A lot of abdominal conditions can be diagnosed using CT scan. Also, it can be used in the lungs. We usually use use basically CT is another form of CT, especially for fibrosis and COPD. And then you have for the brain parenchyma. By brain, this is where I mean acute strokes. It's perfect. CT is perfect to diagnose hemorrhagic strokes. Because an MRI is going to take you, I don't know, 2 hours, maybe 3 hours. A CT can be done in 10 minutes and you can save a patient's life, right? So it's very useful when it comes to hemorrhagic strokes, not ischemic strokes. And then you have CT angiography, where you just inject contrast in the arteries or veins of the patient, and you can visualize it then. And this is important in aneurysms and peripheral artery disease. So basically in peripheral artery disease, what happens is that, you know how in myocardial infarction, you have atherosclerosis of the coronary arteries. You basically just have atherosclerosis of your popliteal artery, all right? And that is peripheral artery disease. Now, CT in trauma, as I said, you can do it for the brain, for the abdomen, for chest. It's very helpful with or without contrast. It all depends on the clinical scenario itself. All right. Again, more applications. So ICP is basically intracranial pressure. And when you have a high intracranial pressure, this could be an acute condition or a non-acute condition. When is it an acute condition? It's an acute condition when there's bleeding inside your brain. That's an acute condition where you have an increase in intracranial pressure. When is an increase in intracranial pressure a non-acute condition? This is in cases like an abscess or a tumor or any mass leak inside your brain. It's not it does increase the intracranial pressure. Now, why is it important to detect increase in acute conditions? Because there's a risk of progression to herniation. So your brain will just herniate through your magnum, which is the cancer. There isn't a lot of them, but there are some. So you need to remember you can't use them on pregnant women because they use ionizing radiation, just like X-rays. Right? They use X-rays. So don't use CT scans on pregnant women. And when you have a pregnant lady in your ER or in your clinic, always go for either ultrasound or an MRI. Don't go for a CT or an X-ray. If you're planning on using IV contrast, make sure that the patient is not allergic to the IV contrast because it can trigger an anaphylactic reaction. And any patient with renal impairment also, if you plan on giving IV contrast, make sure the patient is not renally impaired because contrast media is excreted using your kidney. And you're going to learn later on when I discuss the contrast lecture how it's very important to assess the renal function of a patient before administering IV contrast media, all right? Okay, so I hope, as I said, you remember the physics lecture. So can someone write in the chat, what window is this? By the way, this lecture is a lecture that I edited a bit, all right? I added some slides or removed some slides and whatever. So keep that in mind. We've got our first question here. All right. So is CT contraindicated for children? To a certain extent, yes, it is. It depends how young the child is, all right? So you preferably don't do a CT scan on a 2 or 3 year old because they're still growing, all right? So preferably don't do that unless it's indicated. It's indicated in the clinical scenario, all right? But the absolute contraindications, keep them in your mind: pregnancy, IV contrast allergy, and renal impairment. Those are a no-no. You don't do CT or give contrast to them. All right. So yeah, keep that in mind. So can someone tell me what this window is? This is a bone window, exactly. You can see that everything else is obscured. The only thing you can see is the skull, and you can see also the mastoid air cells, which is basically made up of bone. All right. So this is a bone window. Perfect. Can someone tell me what this window is? All right, it is a brain window, but we don't call it brain window. We call it a soft tissue window. But you're right. You're perfectly right. This is a soft tissue window. Amazing. Yes. So you can see that the brain parenchyma is clear. You can see most of the things. You can see the ventricles. You can see the gray matter, the white matter. So the brain is visible. So this is a soft tissue window. But when you look at the bone, it's completely white, right? So it's obscured. You can't see any fractures. You won't see anything in the bone in this window because it's completely white. So this is a soft tissue window. Perfect. All right. So this is the doctor is just basically trying to tell you what level you're on right now. All right. And I want you guys to focus on the ventricles because those are, for me personally at least, are the landmarks that I use to identify where I am in the brain, or in the skull. So you can see here that this is the lateral ventricles. All right. So once you can see that the lateral ventricles are there, you are in like you're like in the middle of the brain. You're right here. All right. You're not in the on the top of the cortex, and you're not down and the brainstem. You're just in the middle. I can't see any hemorrhage here, to be honest with you. Looks perfectly normal to me. I can't identify any problems in this image. But this is just basically to tell you the levels. All right. I don't think there's a pathology in this. But yeah, and that's in A. So you can see the lateral ventricles. Now, if you go to B, you can no longer see the lateral ventricles. All right. But you can see this one, which is either the third or the fourth ventricle. And either ways, you are and the base. All right. So this should be the brainstem, since it's anterior to your third or fourth ventricle. So this is the brainstem. All right. And then you go down, you can start seeing the mastoid air cells right here. This is when you know you're at the bottom, and you can now see the fourth ventricle, and you can also see the eyes. All right, your eyeballs are right here. So this is basically where your brain ends. All right, and this is most probably the cerebellum. All right, so this is another CT. A, can you guys tell me, is there anything wrong with A? All right, there's nothing wrong with A, perfect. What about B? Yes, Sarah, exactly. There's atrophy, right? You can see that there's atrophy because of one more obvious reason, the ventricle. The ventricles are really dilated here. Those are really big ventricles, all right? And this is not normal. Like under normal circumstances, this is not normal. Now, this though is normal in some cases, and this one case is aging. All right, the more you grow, the more your brain atrophies and it loses mass. And when your brain loses mass, it makes more space for your ventricles to expand and more CSF. All right. Would this patient have an increased intracranial pressure because, more space for the ventricle? Would this patient have an increased intracranial pressure? No answers. All right. This patient won't have an increased intracranial pressure because the loss of mass kind of equates for the increase in the ventricle size. All right. So keep that in mind. those patients usually don't have an increased intracranial pressure. So yeah, so this is normal. Now, when is atrophy abnormal? When can you tell that the patient has pathological atrophy of his cerebral cortex? You can have atrophy of your cerebral cortex in degenerative diseases, in Alzheimer's. Yes, perfect. Perfect, Faris. In Alzheimer's disease, you do lose your mass due to a pathological reason, all right? It's not normal. Also in alcoholics, so keep that in mind. Alcoholics have something called ex vacuo hydrocephalus, which also happens because of atrophy of the brain parenchyma, all right? So alcoholics and degenerative diseases like Alzheimer's disease. Perfect, guys. All right. Now, I made this slide so you can like clinically correlate a patient to the presentation, all right? So because you don't want someone to come to your ER and the patient has a headache, all right, and other presentations, and you don't have differentials in your mind. You always need to have differentials in your mind so you can pick the correct imaging modality, all right? Because what tells you that you should do a CT and not an X-ray or an MRI? You know, it all depends on your clinical presentation. You need to decide whether this patient should go for or so you need relation. You can't just be like, yeah, all right, this patient has a headache, he should go for a CT, right? This is not how it works, right? So I made this table and I made another one later on. You're gonna see it, and this is basically for strokes and hemorrhage inside the brain. You can go on your own and like read through it, but it's very helpful. It helped me at least in my radiology final. So yeah, take a look at it. It's interesting. Now, these are the types. Yes, I will send you those slides. Everything I'll send to GND, and GND will send you guys, inshallah. Those are the types of brain hemorrhages that we have. Again, I want you guys to remember, we do not do CT in ischemic strokes. CT will not detect an ischemic stroke in time. It will take hours for a CT to detect ischemic strokes, but CTs will detect hemorrhagic strokes immediately. All right, that's why we always do CT scan, non-contrast CT scan for patients who are we suspecting strokes. All right, so keep that in mind. You always do CT non-contrast for stroke patients, because if this is a hemorrhagic stroke, you cannot give thrombolytics or fibrinolytics to this patient, because you're going to make it worse. You're going to increase the bleeding in a patient who's already bleeding. So if you do a CT scan for a stroke patient and you see bleeding, do not give TPA, for example, right? Because you're going to worsen the bleeding. But if it's an ischemic stroke, you can give fibrinolytics, all right? So we use CT to detect hemorrhagic strokes, and you have 4 types of hemorrhagic strokes. You have the epidural strokes, or the epidural hemorrhage, the subdural hemorrhage, all right, the subarachnoid hemorrhage, and the intracerebral hemorrhage. Now, epidural hemorrhage or hematomas, all right, they are above the dura. That's it. Subdural are below the dura, all right? Subarachnoid are under the arachnoid, and intracerebral, also called intraparenchymal hemorrhages. They are inside the parenchyma of the brain, all right? All the other 3 are outside the brain. They do not affect the parenchyma of the brain, but the last one does. All right. Now, how do you differentiate between those on a CT scan? And I'm going to go through it right now. All right. Straightforward. Tell me, what is this? What's your diagnosis? This is subarachnoid. Now, there's a reason why you said subarachnoid in Egypt, huh? The reason is that every type of bleeding has a pattern on CT. There's a pattern that you need to see on a CT to be like, yeah, it's a subarachnoid, this is midriage, this is midriage, right? So you need to keep a pattern follow of a bleeding. All right. This is a subarachnoid hemorrhage. Thank you, Najib. I was just gonna say it. It's a star-shaped hemorrhage, right? So basically the arachnoid kind of like curves around the brain parenchyma, all right? So it surrounds the brain parenchyma. These are lobes of the brain, all right? And this is the brainstem or whatever in the middle, all right? So the bleeding is going to be along those cisterns. They're going to be along those sulci and gyri right here, giving you an appearance of a star shape, all right? Now, this is not always what happens. This is the most obvious subarachnoid hemorrhage I've ever seen, but basically that's what happens. The bleeding is not going to be on the periphery, all right? And it's not going to be inside the brain parenchyma. It's not going to be inside one of the lobes. It's going to be in the cisterns that surround the lobes, all right? And that's what we call a subarachnoid hemorrhage. Now, a subarachnoid hemorrhage will have a thunderclap headache. The patient is going to say the most painful headache of my life. Patient is probably hypertensive, stuff like this. All right. Again, if you go back to here, you're going to see it. Thunderclap headache, nausea, vomiting, ruptured aneurysm, hypertensive patient. Just keep that in mind. Okay. Now, this is a young gentleman with acute onset headache. What do you guys think? What is this? No takers? Yes, Faris. This is another subarachnoid hemorrhage. Again, if you follow the cisterns, you can see that there is hyperintensity in the cisterns, which means there's a subarachnoid hemorrhage, right? This is normal. So if you can see, if you follow the cisterns, there's bleeding. There's hyperintensity, and hyperintensity means fluid, and this is probably a bleeding, all right? Okay. Now, to differentiate between epidural and subdural, hyperintense is blood instead of CSF. Yes, Faris. Hyperintense. Actually, they can both be hyperintense, but it depends on the presentation. Yani, if it's acute or chronic. So, مثلا in a subdural hematoma, bleeding is going to be dark, right? So if you can see to this one right here, this is subdural hematoma, but this one is acute because it's bright. So bright blood means acute. Dark blood means chronic, right? So keep that in mind. Now, epidural and subdural, as I said, the differentiation is where the bleeding is from. In epidural, it's above the dura. In subdural, it's under the dura, all right? And in epidural, the bleeding itself takes a convex shape, right? It becomes like this, all right? This is a convex. But in the subdural, it gets a lens-shaped hemorrhage or a concave, right? So this is a concave, this is the bone, this is a concave, all right? And this is a you guys get it, right? I am not that flexible with my hands, my bad. All right. So a convex lesion, all right, remember, is an epidural. A concave is a subdural, all right? Now, in our brain, between our brain and our dura or the surrounding structures, we have suture lines, all right, that attach to the brain. Now, those suture lines attach the dura to the skull, all right? So if anything is bleeding above the dura, the sutures is going to limit the bleeding. It's not going to allow the bleeding to spread. You won't see the bleeding going all the way through here because you have a suture line right here and you have another suture line right here. So the bleeding is going to be contained there. It respects the suture lines. That's an epidural hemorrhage. A subdural hemorrhage, because it's under the dura, it won't respect those lines because the lines are above the dura. So it's just going to keep spreading and spreading and spreading across the hemisphere. Okay, so you can see here that the suture line limited this one, but the suture lines here did not limit this one because they are above the bleeding. All right, so keep that in mind. And again, a subdural and epidural both think of trauma patients. All right. In an epidural hemorrhage, think of a motor vehicle accident, but in a subdural hemorrhage, think of an elderly patient who fell. all right? So keep that in mind. I always think of subdural as old people who fall a lot and they were in the bathroom and just slipped, all right? And then 2 or 3 days later, they presented to the ER with nausea and vomiting and signs of increased intracranial pressure, all right? So keep that in mind. Yeah, I don't know if you guys need to know which vessel bleeds in each one, but I'm just going to say it for the record. In epidural hemorrhage, this one, the middle meningeal artery is the one that bleeds. The middle meningeal artery is the one that bleeds. And to make the middle meningeal artery bleed, you need a high force trauma. So motor vehicle accident, all right? In the subdural hemorrhage, what bleeds are the bridging veins, right? So hina, it's an artery, and hina, it's a vein, all right? And the bridging veins are the ones that bleed. And because it's a vein, it doesn't bleed as much, so the presentation takes longer. So if the patient hurts himself today, he might present 3 or 4 days or even weeks later with the signs of increased intracranial pressure, all right? Artery for subdural, vein, artery for epidural, vein for subdural, all right? So yeah, just for the record. All right, so you have an elderly patient who awakens right body weakness. What do you guys think this is? All right, the parenchyma is affected. Do you guys think this is a hemorrhagic stroke or an ischemic stroke? It is an intracerebral problem, but is it a hemorrhagic? Well, okay. This is not a hemorrhagic stroke. This is an ischemic stroke, right? An ischemic stroke is more uniform, all right? It's more it's kind of, I don't know how to say it, but it's more limited, you know, it's well defined. The borders are clear and sharp and well demarcated, all right? So if you take a look at this part, all right, this is the area where the middle cerebral artery supplies, all right? So this is a stroke that affects the middle cerebral artery. Now, if the artery is affected or thrombosed, all right, or because of an atherosclerotic plaque, the whole area that is supplied by this artery is going to be affected. You're going to find it dark, all right? It's going to be dark in color. Now, it's very rare to see an epidural hemorrhage that's dark in color, because remember what I said, blood in acute conditions is bright, it's not dark. But over time, when it becomes chronic, blood will turn black or turn dark, right? So the only time I'll think of hemorrhage, and the hemorrhage in front of me is dark in color, is a subdural hemorrhage, which is this one. This is the only time I'll think that this might be a chronic subdural hematoma, all right? But it's very hard to see a chronic epidural hematoma. Patient will be dead way before it becomes chronic, all right? Because it's an artery bleeding, it's not a vein, okay? So keep that in mind. This is an ischemic stroke. It's not a hemorrhagic stroke, all right? Because as you can see, it's well demarcated, all right? There is no differentiation between the gray and white matter. Here you can tell the difference between the white matter and the gray matter, right? But here, there's no line of differentiation, all right? It's all dark. It's intraparenchymal. The parenchyma itself is affected. So this is an ischemic stroke, all right? Now remember, this is the middle cerebral artery. If your anterior cerebral artery is affected, this area will be dark, all right? If your posterior cerebral artery is affected, this area is going to be dark. So think of the brain as portions, as chunks, all right? If this whole chunk is affected, this is an ischemic stroke, all right? So keep that in mind. And usually an ischemic stroke on a CT, this patient probably presented like 5 or 6 hours after he had this or she had the stroke. So this is a late presentation since they saw it on a CT, all right? Because ischemic strokes are not used to detect, CT scans are not used to detect ischemic strokes, all right? Just keep that in mind. Do you guys have any questions about hemorrhagic strokes or ischemic strokes? So anterior posterior cerebral artery are not acute. No, they are acute. All ischemic strokes are acute, but the only time you can have a chronic present is when it's a subdural hematoma, all right? So a subdural hematoma can take time to present because it's a vein affected, and veins don't bleed as much as arteries. Arteries bleed way more profusely and way rapidly than veins, right? But any other stroke, think of it as an acute presentation. Someone will have stroke right now. 1 minute after this patient's blood vessel is obstructed or starts bleeding, they're going to have symptoms. They're going to have slurred speech. They're going to have a problem in vision. They're going to have problem, they're going to have nausea, vomiting. They're going to have weakness, all right? So stroke is an acute condition, but CT is not used for ischemic strokes because they don't appear on ischemic strokes. For ischemic strokes, we use MRI. MRI can detect an ischemic strokes in after 5 minutes. So mostly all acute except subdural. Basically, you can say this, all right? But subdural can also be acute, all right? It depends on how many bridging vein is being torn. So if you have one bridging vein that's torn, this can be chronic, right? It takes time for this one single small vein to bleed, right? But if it's multiple bridging veins that are being affected, this is going to be acute, and it's going to be an acute subdural hematoma. All right, great. So keep in mind, guys, CT is used to detect if there's bleeding or not, all right? If this is a hemorrhagic stroke or not, because your intervention or your medical treatment is going to be completely different if this is hemorrhagic or ischemic. If you do a CT scan in a patient with symptoms of stroke and you don't see anything, this is most probably an ischemic stroke, not hemorrhagic, all right? So keep that in mind. If you want to make sure, if you really want to make sure it's hemorrhagic, it's ischemic, your modality of choice is an MRI. MRI will detect an ischemic strokes after 3 minutes of it happening, right? While a CT takes 3.5 hours or 4 hours to start detecting ischemic strokes, which is too late. Anyways, let's get back to this. So this is a brain, all right, it's right there. It says brain tumor, all right. What other differential diagnoses do you guys have other than a brain tumor for this? If you see this in front of you, what will you start thinking other than brain tumor? An abscess, yes, perfect. This, without contrast, an abscess is very viable option, but it is not. This is not hemorrhage, right? Because if you guys can see, it's affecting part of the brain, or it's affecting a small part of the brain that's well demarcated, and it's circular in formation, all right? An ischemic stroke is going to affect a whole part of the brain, right? It's not going to be the small part that is circular in shape, right? So yeah, an abscess is a good choice, and a tumor is a good choice. Now, and a cyst, yes. Now, how can you differentiate between a brain tumor and a cyst? Basically, you just give contrast. Now, in a tumor needs blood supply to live, to survive, and to proliferate and become bigger and kill a patient. A tumor needs blood, it needs nutrients, right? That's why a tumor is a highly vascular structure, while a cyst or an abscess is not. Blood vessels will not penetrate abscesses or vessels or cysts, all right? So keep that in mind. So once we gave this patient contrast, can you see how it brightened up? It became bright in color, right? That's because the contrast traveled all the way from the blood to the tumor, because the tumor contains blood vessels. So if you have this mass right here and you give contrast and it becomes whiter in color, this means that this mass contains blood vessels, and this is most probably a tumor. All right, so keep that in mind. I'm not sure if you guys took it yet, but do you know what an arteriovenous malformation is? No? All right, never mind, out of your scope. So as I said, you have a mass in your brain. Give contrast. If the contrast becomes whiter in color, it's a tumor. If it doesn't, it's something else, most probably an abscess or a cyst, right? So keep that in mind. All right. Interesting. Okay, so these are the types of edema on CT scan. I'm going to come back to it. Just remind me at the end of the lecture to come back to this one.
Is also a...
Whoa. All right. Okay, so now we're done with the brain. Do you guys have any questions regarding the brain? Ischemic strokes, hemorrhagic strokes, tumors, whatever. All right, great. All right, so this is a CT scan of a C-spine, right? A C-spine is your cervical spine, basically. And we usually use these in cases of motor vehicle accidents or trauma, basically in the ER, right? Because if a patient comes to you with a head injury, right? After making sure that the brain is fine and everything is cool with the brain, you need to rule out any injury to the C-spine, right? Because in the C-spine, you have your spinal cord, but the problem is that the spinal cord at this level basically supplies your whole body. So if anything is injured, if any part of the spinal cord is injured in the C-spine, the effects or the consequences of this injury is way worse than the lumbar spine or the thoracic spine. All right. So you need to make sure that this patient has no fractures, no injuries in his neck, and if he does or she does, you need to stabilize it before you do anything, because this patient will probably need. What if the patient needs intubation, all right, or the patient needs surgery or whatever? You're going to manipulate the neck, and if you manipulate the neck and one of the fractured pieces injures the spinal cord, and it's not good news, right? So you need to make sure that everything is fine with the C-spine, especially in trauma situations. All right. So as you can see here, this is the C-spine. All right. This is the spinous process, which is what's like behind. You know, when you feel your back, those are the spinous processes. Those are the spinous processes. All right. And you need to make sure that these are intact. And obviously in this CT scan, they are not intact. You can see that there's fragmentation. This piece is not attached to this piece of the vertebral body. So you have bilateral fractures in the C-spine, right? I think that's it for this part. There's nothing more I can talk about, to be honest. It's just a fracture, you know? And if you see this as trauma situations, we use CT or X-ray. I don't know about because each hospital has its own protocol, but at least in KFSH, the protocol would be a pan CT. What's a pan CT? A pan CT is a CT head to neck. Head to neck. What was that? Head to toe. Everything. A CT of everything, including the head, chest, abdomen, to make sure that there are any active bleeding. There's no fracture of vital structures like the C-spine or the skull. All right. So we usually go for pan CT, unless, for example, the patient is coming with dyspnea and can't breathe and is getting cyanotic and tachycardic, and you're suspecting pneumothorax. In this case, a chest X-ray is as indicated. But for this, we go for a CT scan of the C-spine, especially the C-spine. Second picture, yes, there is a problem. See how there's like spaces between each vertebral body, all right? There's no space here because the fracture kind of dislocated inferiorly, all right? So it's fractured, and not only fractured, it's displaced too, all right? So yeah, so the C-spine fracture, we use CT, yes. C-spine fractures, go for CT. All right. Now there's a difference between C-spine fractures and pathologies. A fracture is an acute problem. You need to deal with it right now. But if you have a C-spine degeneration or a C-spine osteoarthritis, this is a different story. You can go for an MRI then, or an X-ray. Right. So keep that in mind. Acute case, C-spine, CT. All right. All right, I think we're good with this. Okay. What's the window? Yes, this is a lung window, all right? Because you can see that everything in the mediastinum is obscured. The heart is not there. The vessels are not there. Your bones are not there. You can barely see them, all right? So this is a lung window. And we use lung window to see the lungs, right? So you want to see if there's any pathologies in the lung. Now, what window is this one? It's a long word, so I'm gonna give you guys some time to write it. This is a mediastinal window, yes, because you can't see the lung, absolutely nothing, all right? And you can see the mediastinal content. No, see, no, see how you can see the heart, you can see the aorta, you can see the bifurcation, you can see the vessels, right? So this is a mediastinal window, right? The bones are kind of seen here, right? But this is not a bone window because it's not seen throughout. So if you have a pathology somewhere in your rib cage, it's not going to be apparent. Right? So this is a mediastinal window. Now this is a bone window, right? No lungs, no heart, no vessels, but only bones can be seen. All right? So this is a bone window of the chest. All right, I think that's the same thing basically that I just talked about, nothing more. All right, so this is the second just table that I made, all right, for chest pathologies. You need to know about aortic dissection, embolisms, pneumonia, and pulmonary fibrosis, right? Again, I don't want to spend a lot of time on it. If you guys want to go through it, feel free to do that, although I would recommend it. It's very important, again, to correlate your radiological choice with the clinical presentation. Not every patient with aortic dissection or not every patient with pulmonary embolism will go for a spiral CT, and not every pulmonary embolism patient will go for a VQ scan, right? So you need your clinical scenario, right? So that's why I highly recommend you guys go through this. All right, a middle-aged woman with shortness of breath for a few hours. You have a CT scan in a mediastinal window. What do you guys think is going on? No idea what's going on? All right. Yeah, there is an embolism, all right? Now, is the embolism on the right, let's say this is A and this is B. Is the embolism in A or B? Yeah, the embolism is in B, all right? This is a normal CT scan, all right? There's absolutely nothing wrong with it, all right? This is the pulmonary artery. This is the vena cava, this is the aorta, and they all look clear. there's nothing inside them. They're just blood, all right? And this is with contrast, by the way, guys, so keep that in mind, all right? This is with contrast. That's why the blood is so bright, all right? Left pulmonary artery in B. Okay, you're right, it's in B, but it's not only the left pulmonary artery. If you can take a look here, see, this embolism extends also to the other side, all right? So this is what we call a saddle embolism. A saddle embolism is basically an embolism that would affect both of them. All right, so keep that in mind. This is a pulmonary embolism. You can see the pulmonary artery and the bifurcation of the pulmonary artery, and you can see that there's this dark thing inside. All right. Now, an embolism will not uptake the contrast. That's why it's going to stay darker than the blood. So anything inside the vessel is just an abnormality. And in this case, because again, see how I said middle-aged women, right? Women are at higher risk of developing thromboembolic events, all right? Because they're usually predisposed to it, all right? Smoking does too, oral contraceptives does too, all right? There's a lot of clinical correlation to why you might start thinking of pulmonary embolism in a middle-aged woman, all right? So, yeah. Same thing, you can see here to the pulmonary artery, this is the bifurcation of the pulmonary artery, and you can see another saddle embolism, right? This is a clear one, this is normal, and this is one with a saddle embolism. Do you guys have any questions regarding pulmonary embolism? Take that as a no. Okay. Now, another middle-aged woman with shortness of breath and fever. Fever. What do you guys think is going on? Perfect. Yes, this is pneumonia. All right. So when you have shortness of breath, empyema, yes, perfect. There's a collection of plus here. So when you guys see a patient who is having respiratory problems, all right? So it's dyspnea, cough, wheeze, crackles, whatever, right? And the patient is feverish. Your top differential is always pneumonia, all right? This is an infectious process until proven otherwise, okay? So keep that in mind. Your first line of investigation in a pneumonia patient is not CT. Fever and respiratory problems, so cough, dyspnea, shortness of breath. When you auscultate the patient, there's wheezing or whatever, respiratory problems with fever, you need to start thinking of pneumonia. Okay. Now, your first line of investigation, radiological investigation in this patient is not CT. It's an X-ray. All right. I'm not sure why would you do a CT in this patient unless the X-ray doesn't show you what you need to see. Sure, you can go for a CT, but always remember pneumonia. First line of management or first line of investigations is an X-ray. Right, normal X-ray. So as you can see here, I'm not sure what this is, to be honest with you guys, but we're just going to look at this one. This is a much more clear picture. All right. Now I want you guys to compare the right lung to the left lung. All right. This is the same window. All right. Can you guys see how this is pitch black? Yeah. You can see how this is just completely dark, because this is a mediastinal window, and in a mediastinal window, the lungs are pitch black. All right. So remember that. So this is a normal lung. All right. While this lung is sequestering stuff, it's holding stuff inside of it. All right. And if you guys look here and here, this is it's homogeneous in color. All right. And it being homogeneous, meaning it's one thing. It's either tissue, it's one type of tissue, or it's one type of fluid, or it's one type of whatever, right? So it's homogeneous in color, and this is pus, right? This is pus, and pus will be homogeneous on any imaging modality because it's made up of the same stuff. And you can see that the pus is compressing the lung on both sides, and this is a collapsed lung, right? Now, can someone tell me, is this collapsed lung normal? Like if I take a piece of this lung and I assess its respiratory function, will it be normal? It won't be normal. Why? Because if you, again, a lung on a mediastinal window is black, right? If I saw this and this lung is black, I would say this is a normal lung, and it can do its function of respiration and oxygen change, all right? But since you can see it, which is abnormal, right? It should be pitch black, but you can see it. This means that this lung contains stuff too, all right? There's an inflammatory infiltration of this lung. There's neutrophils, there's lymphocytes, there's inflammation in this lung. And inflammation always means edema, all right? So inflammation, edema. So there's inflammation in this lung with edema, all right? So this lung does not function properly. I think that's it for this slide. You guys have any questions in this slide? Yeah, there you go. The thickness of the borders. Oh, the pleura, you mean? Yeah. It's not really significant in this case, all right, because you're not really worried about the pleura. The heart is normal. The heart looks normal to me. Yeah, the heart looks normal. It's normal in size. Chambers are obscured a little bit, but you're not supposed to see the chambers on a CT scan or on like one slide of the CT scan. You have to go through multiple slides to see the chambers of the heart. But in this instance, yeah, it looks normal to me. So yeah, as Faris said, the pleura is thickened, all right, which is also an indicative of an inflammatory process, because as it thickens, it means it becomes more edematous. There's more accumulation of the fluid inside the pleura, all right? But in this instance, you're not really worried about the pleura as much as you're worried about what's going inside the pleura, so the lungs and the pleural cavity, all right? But yeah, nice catch. So yeah, this is an empyema. Empyema is basically a collection of the abscess, all right? Collection of the pus, sorry, on both sides. This is an empyema, and you have pneumonia inside the lung parenchyma, right? The doctor put like a circle over here if this is an abscess or not. I don't think it's an abscess because it's. Give me a second. I'll just plug my iPad in the charger. I don't think it's an abscess because it's not well demarcated, all right? You can't really tell where the borders are, and it's not that different in color from the rest of the lung. So I don't think I would say that this is an abscess. All right. Now, this is a middle-aged man with upper back pain and dizziness. What do you guys think is going on? No takers? All right. So upper back pain, all right? The doctor should be more specific with you guys because in this case, the pain should be an upper back chest pain that radiates to the, so it's a chest pain that radiates to the back. It's not a back pain, right? So it's a chest pain that radiates to the back with dizziness. Now, if you think of dizziness, you think of two organs. You think of the brain and you think of the heart. If the heart is not pumping enough blood to the brain, you get dizzy. If your brain is not functioning well, you get dizzy, all right? So since this is a chest x-ray, you start thinking of the heart and its vasculature as the problem, all right? Now, this is the right side of the body, and this is the left side of the body, and that's what I use to differentiate between the aorta and the vena cavas, right? And since this is the left side of the body, this is the aorta, and I want you guys to take a look at this. Can you see this weird line in the middle of the aorta, bulging? This is an aortic dissection, all right? And yes, this is an aortic dissection. Perfect, Ahmad. So the thing with aortic dissection is that it could happen in elderly, or it can happen in middle-aged men. Can someone tell me when can it happen in middle-aged men? Like in elderly, everything gets weak, patients become hypertensive, whatever. But in a middle-aged man, why would a middle-aged man get an aortic dissection? Aneurysm? I'm not sure what aneurysm. Sure, but why would a middle-aged man get an aneurysm? It's the same concepts, right? High BP, sure, but high BP in a middle-aged man is not common. Sure, no, stress, يعني. My mom tells me this. So basically, in a middle-aged man with an aortic dissection, this middle-aged man should have what we call yes, thank you, Shaima, a congenital problem. It's a connective tissue disease. Now, your blood vessels are made up of collagen, right? And collagen is what makes your aorta strong. Perfect, Sarah. Yes. Like Marfan syndrome and Ehlers-Danlos syndrome, those two make your connective tissue weak. All right. And if your connective tissue weak, you will become more predisposed to vascular problems like dissection and aneurysms. All right. So if you think of a middle-aged man up with a chest pain radiating to the back, dizziness, unequal blood pressures in both hands, think of a dissection in a Marfan patient. All right. So keep that in mind. But normally, if the patient has no syndromes or whatever, this patient will be an elderly patient. The patient would have either atherosclerotic problems, or the patient will have a bicuspid aortic valve. The patient might have hypertension, and my patient might be smoker, right? So think of those things. But hypertension is probably the most important risk factor for dissection in elderly patients. All right. So keep that in mind. So this is the aorta, and you can see the flap. All right. On the outside, this is the true lumen of the body of the aorta, and this is the false lumen of the aorta. You guys know what the dissection is, you know? صح? Just to make sure, I wanna be clear about this. All right. So you don't know what? Okay. So the aorta has three layers, right? The intima, the media, and the adventitia. All right. Now, what happens is that the intima of the aorta kind of has like a slit. All right. There's like a small crack in the intima. All right. And what happens is that blood will start going into that slit. All right. And it will start pushing through, and it will separate the intima from the media. All right. So that's basically what a dissection is. This small slit is going to allow blood to go into the wall of the aorta and keep on splitting it, and splitting it, all right? And this can progress throughout the whole length of the aorta, all right? That's why you have this lumen right here, okay? Perfect. And by the way, dissection is an acute condition. It's a top emergency, high mortality rate. A lot of patients die. So yeah, keep that in mind. So this is a 55-year-old male with shortness of breath for 6 months. He's 55. He has shortness of breath. All right. Yes, fibrosis is a good differential. And he has this shortness of breath for 6 months. All right. Effusion. Okay. What else? All right. You guys are right. This fibrosis. All right. So Again, any respiratory problem in any patient, always do an X-ray first, right? And then go to CT if you can't see anything. For the effusion suggestion, this can't be an effusion. Although if you said pulmonary edema, it could have been a correct answer, all right? Or it could have been debatable, but it's not an effusion because an effusion will blunt your costodiaphragmatic angle or your costophrenic angle. See how sharp and well demarcated it is right here, right? You can see it. So this is not an effusion. But whoever said fibrosis, good job. This is a fibrosis. This is a fibrotic patient. Ruled out infectious problems like pneumonia and whatever, and we not inflammatory problems too, because of the lack of systemic symptoms like fever, rash, whatever, and the period of the presentation. See how it's 6 months? No one has pneumonia for 6 months. You will be dead by then. All right. So if you have 6 months presentation of shortness of breath, you guys hear me or am I lagging? Great. All right. So this long period of presentation, it suggests other conditions, a more chronic condition. All right. So yes, this is fibrosis, and when you do a CT scan, this is what you see. Now, this is a high resolution CT scan, right? This is the one I was trying to tell you about at the beginning. A high resolution CT scan. Can you guys tell me what you can see? All right, COPD, yes, okay. But radiologically, how would you describe it? Okay, I'll go ahead and tell you guys. You can see holes, all right, yes, holes in the lungs. See, this is what we call a honeycombing pattern, all right? Small holes in the lung that are clustered together is what we call a honeycomb, right? So if you can take a look right here and right here, see these two areas, you can see honeycombing. It basically looks like a honeycomb, although I don't see it, but that's what they decided to call it. So I guess we'll just go with that. You can also see bronchiectasis, all right? And what I wrote them all down right here. Give me a second. Yeah, I wrote the, whoa. You're not supposed to see that. All right, so I wrote them down right here. You have reticulations, bronchiectasis, and honeycombing. Now, what is bronchiectasis? Bronchiectasis is basically, it's not written here.
You already know that.
So, all right. So bronchiectasis is basically dilation of the bronchi. All right. When you see them, you can see it right here. You can see how it's right here. You can see it right here. See this part right here? It's really white, isn't it? It's very obvious that it's white. So this is what we call bronchiectasis, and this is what we call honeycombing. And reticulations are basically just white lines together, and this is the actual fibrosis. The reticulations are the actual fibrotic process that's going on. And I want you to compare this to the normal lung, all right? And you'll see what I'm talking about. You don't see bronchiectasis, right? You don't see any dilated tubes anywhere. You don't see any honeycombing, all right? So this is what lung fibrosis looks like on a CT scan. Again, no problem. So the patient will probably be old patient, all right? And the patient will probably have shortness of breath for a long period of time, all right? And when you do a CT scan, this is what you're going to see. You're going to see three things. You're going to see honeycombing, you're going to see bronchiectasis, and you're going to see reticulations, all right? Now, what are honeycomb or honeycombing? Basically, small holes in the lung clustered together, all right? So they become small, next to each other. And you can see it right here. This area right here is honeycombing, all right? This area right here is honeycombing, all right? This area right here is honeycomb, all right? Small holes in the lung that are clustered together, okay? Now, what are reticulations? Reticulations are the actual fibrotic tissue, right? And fibrotic tissue appear white on a CT. So you can see, can you see those white lines right here? Can you see those white lines right here? This small one, this one right here, this one right here. those are what we call reticulations, and those are the actual fibrotic tissue, all right, or the scarring. And finally, you're going to see bronchial cases. Now, what are bronchial cases? You know how we have bronchioles, the ones that deliver air to the lungs, they become dilated. You start seeing them more prominently. And you can see them right here. See how it's kind of a tube, a hollow tube. But the most prominent bronchial cases in this lung is this one right here. This one is the most obvious one, right? So it's just dilated bronchial tree, right? And that's basically what you see on lung fibrosis. Is it clear, or do I have to repeat it again? I absolutely don't mind repeating it third and a fourth time. Just tell me. Clear for everyone? Perfect. All right, let's move on. Okay.
Another example.
Oh, okay. Now, a splenic laceration, I want you guys to remember your spleen is on your left side. It's next to your liver, right? So when you see the liver here, it's the one next to it is the spleen. All right. Now, a splenic rupture is going to happen in patients who are trauma patients, all right? Motor vehicle accidents, hit with a baseball, whatever, right? So it's going to be a trauma patient, all right? And the patient might be hypotensive, in shock, signs of bleeding, because the spleen is a site of sequestration of blood. It stores blood. So it can keep a lot of blood inside of it and outside of the vascular system. So if this patient has a splenic laceration and is bleeding, this patient will be hypotensive, tachycardic, in signs of shock, basically. And the patient will be coming from a trauma scene, okay? Now the spleen should look the same color through and through, all right? This is the normal color of the spleen, right? It just looks like the liver. But can you see this darkened area? See this darkened area? This is a sign of laceration and bleeding, all right? I guess if you do an ultrasound, you're gonna see that there's accumulation of fluid in the peritoneal cavity. Okay. Honestly, for this, I would just memorize it. All right. There's not really much to explain here. Just when you see this splenic laceration. All right.
Another. Now you might have noted.
Okay. So for the selecting of the appropriate radiological examination, as I said, you can't just choose CT for everything, all right? You can't choose X-ray for everything. You need your clinical presentation, and then this will dictate what you will choose, all right? So you need at the beginning to know what's the chief problem. The patient has what? The patient is dizzy, the patient is tachycardic, the patient is whatever, right? And then you need in your mind to make a differential diagnosis, all right? So if I tell you a patient has a chest pain, all right, and the patient is not a trauma patient, he was sitting at home, he is 35-year-old, and he has chest pain, you need to start thinking of diagnoses, right, or differentials. One of them will be, thank you, Omar. Yes, see, your first choice is not going to be a CT scan. It's going to be an X-ray, all right, although it should be an ECG aslan, but ECG is not a radiological exam. I'm talking about radiology here. So X-ray is always your first choice, all right? But let's say this patient is a 35-year-old pregnant lady. Would you still do a CT or an X-ray? Exactly. Oh, see, no, you don't do ultrasound on the chest. That's the thing. You do not do ultrasound on the chest. It's pointless. You go for an MRI. See? Let's say that this patient, exactly, it's an MRI. So let's say the patient is a 35-year-old pregnant lady with, let's say, her calf is pain, like she has calf tenderness. Her calf is in pain. It's reddish. It's discolored, and she can't move it. No history of trauma. What are you gonna do? Pregnant lady. No, you won't do an MRI. You'll do an ultrasound. Thank you, thank you, Sarah and Shayma. See, you're gonna do an ultrasound. Why? Why are you going to do it? What's your top differential? 35-year-old, pregnant, calf pain. What's your top differential? Yeah, she is pregnant. All right, we know that. She is in her 30th week. It's obvious that she's pregnant. But what do you think is going on in her calf? DVTs, guys. So yes, DVTs is your top differential in a pregnant lady with calf pain. Anyone with calf pain with no history of trauma, you think of DVTs, all right? And as I said, guys, remember, DVTs, you need to relate it to conditions that make you hypercoagulable. And I said those conditions are pregnancy, being a woman, just being a woman is puts you under more risk of developing DVTs, smoking, oral contraceptives, exactly. See, those things increase your risk of becoming thromboembolic, all right? So it's all about your clinical correlation, all right? If you have a pregnant lady, just don't do CT or X-rays. Just don't do it, all right? Always go for an MRI, always go for an ultrasound, all right? If you have a trauma patient, all right? A trauma patient, preferably always go for CT, all right? If you have a pneumonia patient, preferably go for X-ray, all right? Don't go for more invasive, more, do we use color Doppler use in this case? Because yes, what is this? You always use Doppler ultrasound in pathologies that involve the vascular system. And since DVTs are in the veins, you need to do a Doppler ultrasound. Yes, it is the diagnostic method of DVTs, all right? I have some cases for you guys to go through, all right? And then we can take a break, I guess. So case number 1, an 18-year-old male presents to the ER with abdominal pain, all right? Since the patient presented to the ER, this is an acute problem, all right? The temperature is 37.9, so the patient is feverish. Heart rate is 80 with a right lower quadrant tenderness. What is the appropriate radiological examination in this patient? Anyone else says anything other than CT? Any other opinions? Okay, we have ultrasound here. Great. All right, so it's either CT or ultrasound. Now, why would you do a CT and why would you do an ultrasound? Your diagnostic method for appendicitis, which is what we suspect in this case, right? Because there is no history of trauma and this patient is feverish, so there's an inflammatory problem going on. Your method is always CT, all right? CT is your #1 method for appendicitis. Now, those who said ultrasound, your answer is correct in one case only, in a pregnant lady. If the pregnant lady presents with signs of appendicitis, you will do an ultrasound, all right? So this is appendicitis. You can see that the appendix right here is inflamed, all right? This is the appendix right here, all right? It's going to be on your right side. You're gonna see that the walls are thickened, all right? You're gonna see that there's edema around the appendix itself, right? Can you see this hazy shadow next to the appendix? Pregnant or a child, 3-year-old, use ultrasound. Basically, it's very debatable when it comes to children, all right? Usually you won't see appendicitis in a 3-year-old, but even if that happens, it's debatable, all right? So, but in a pregnant lady, it's an ultrasound for sure, all right? You go for an ultrasound. You don't do a CT at all, especially when the appendix is really close to the baby and the developing fetus. So whatever CT scan you're going to do is going to be of that specific area. So all the radiation is going straight to that fetus, all right? So it's for sure you're gonna do an ultrasound in a pregnant lady, all right? So can you guys see the hazy shadow next to the appendix? That's edema, which is a sign of inflammation. All right. And usually appendicitis happens because there's a fecum that goes inside and obstructs the appendix. And if you can take a closer look, you can see that there's like this white focus right here. That's probably what's obstructing it. Is there a relationship to tenderness? Yes. So basically, a patient with this is the clinical presentation of an appendix patient, right? The patient is going to wake up in the morning with a peri-umbilical vein. The pain is going to be next to the umbilicus, right? The patient might not be feverish by that. Over the course of the day, the pain, there's no tenderness, okay? The patient is in pain right now. Isn't choosing ultrasound or CT. No, there is no, it doesn't matter if the patient is in tenderness, if the patient has tenderness or not. It doesn't matter, it doesn't affect your modality. Your modality is always CT scan unless this patient is pregnant, all right? So it doesn't affect it. Because also you need to keep in mind, the tenderness in an appendicitis patient is not going to be direct tenderness, it's going to be rebound tenderness, right? So once you put your probe on the patient, there might be pain, but it's not as bad, right? The pain is when you actually go in and then you remove your hand. This is what we call a rebound tenderness. This is where the most pain happens, all right? So no, it's not going to affect your choice. Any question regarding appendicitis and the choice or the modality of choice? Great. Let's move on to the, all right, see. Yeah. Oh yeah, I didn't mention this. It's a CT with contrast, all right? So keep that in mind. Case 2, a 36-year-old male presents to the ER with a right lower quadrant abdominal pain radiating to the groin. All right, so it's a right lower quadrant pain radiating to the groin. Normal temperature, normal heart rate, CBC is normal. When you do a urine test, there is microscopic hematuria. There's blood in the urine. What is the appropriate radiological examination? What do you guys think? CT, okay. CT without contrast. Yes, I am. What else? Ultrasound. Ultrasound is a very valid option, yes. All right. So what are we thinking? What do you guys think is the diagnosis? Why does it really? It's a kidney stone, right? So we're thinking a kidney stone, right? And the best modality to detect a kidney stone is a CT, is a non-contrast. Okay, I'm using my phone now. My bad, guys. Anyway, back to it. So as I was saying, to detect a kidney stone, right? the best modality is a non-contrast CT. You don't give contrast. You don't need contrast anyways, all right? So you give a non-contrast CT. As you can see right here, these are your ureters. They're usually next to your psoas muscle, right? And you can see right here, this radio opaque, really white, small speck of something, which is most probably a calcium stone, right? Now, it's with contrast. Yes, appendicitis is with contrast, right? So contrast CT, appendicitis, non-contrast CT, calcium stones or kidney stones. The ultrasound modality is also used for kidney stones, but it's usually reserved for pregnant ladies again. All right. So you have a renal colic, it's a ureteric stone. Got it. Yeah. Any questions about the stones? Yes, maybe not. Moving on. All right. So a 28-year-old female presents to the ER with abdominal pain, temperature that's 37.9, which is high, and heart rate is normal. All right. Right lower quadrant tenderness. What is the appropriate radiological examination? Is she pregnant? I don't know. Do you know? No one knows. Yeah, ultrasound is your choice because this is a female patient. And she's not only a female patient, no, she's a female patient in her reproductive age. Exactly. There is a possibility for pregnancy here, all right? And if there's a possibility for pregnancy, you don't jeopardize the patient unless you make sure this patient is not pregnant. So your first choice modality is going to be an ultrasound, all right? What do we think is going on? What do you guys, what are your differentials? Let me know. I'm interested for this one. Appendicitis, very valid option, very valid, very valid. Ectopic pregnancy, thank you. What else are we thinking? Right lower quadrant pain in a female, reproductive age. Something that also happens in males. I'm not sure if you guys took it, to be honest. I don't know why I'm expecting you to say it. But torsion, all right? Think about torsion too. Ovarian torsion happens as well as testicular torsion, all right? So see, you keep your options, you keep your differentials clear, right? So this is an abdominal pain. You're thinking about appendicitis, contractile bowel disease, gynecological problems like ectopic pregnancy and ovarian torsion, and the diagnosis is appendicitis, all right? Now, why is it not an ectopic? I could tell it's not an ectopic because of the temperature, right? The patient is feverish, which means the patient is febrile. So there's an inflammatory problem going on, which renders ectopic pregnancy lower. Also, an ectopic pregnancy, the patient will be bleeding, all right? So the patient is going to be tachycardic, not a normal heart rate, all right? So keep that in mind. Ectopic pregnancy, usually there's rupture, bleeding, stuff like that, okay? So this is an appendicitis and you do an ultrasound. So yes, you guys are right. Because they did not mention anything about pregnancy tests. They did not mention anything about the patient's status in regards to pregnancy. So you go for an ultrasound, right? And as you can see here, there's a thickened appendix. It's really thick, and it's bright in color. And bright in color means there's fluid or edema. Edema means inflammation. So appendicitis, right? Do you guys have any questions regarding this one? I feel like it's okay. Okay. Now, you didn't see anything on the ultrasound, and as you can tell, the doctor went on and did a what? What is this? It's an MRI. right? So yeah, at all expenses, just avoid doing a CT. Yes, it is appendicitis. This is the same case. This is the same patient. This is appendicitis, but the doctor, instead of doing an ultrasound, did an MRI. As you can see here again, there's a thickened appendix. All right. There's more findings here. I don't know if you guys want me to go through them, but I will. There's like periappendicular fat striations right here. You can see them here. They're like kind of lines surrounding the appendix, and those are all signs of inflammation too. All right, and look at this. That's a baby. All right. So in a female patient, you don't know the status of her pregnancy. She's in her reproductive age. She has abdominal pain. Assume she's pregnant and do an ultrasound or an MRI. All right, until you get a pregnancy test at least. Now, a 36-year-old slim and tall male presents to the ER following a multi-vehicle accident with headache, several episodes of loss of consciousness, followed by regaining of consciousness and chest pain. Temperature is 37.2, heart rate is 120, blood pressure is 140/98. Patient has right mydriasis and absent right lung sounds. What is the best imaging modality in this case? X-ray, CT, pan CT. Thank you, Shahid. Yes, you do a pan CT scan. Okay, because now let's discuss this question. All right, this patient is a middle-aged patient. All right, that's the first thing. Second thing is that the patient is, they're not going to mention in the question stem that the patient is slim and tall for nothing, right? Because slim and tall are characteristics of what? Marfan's. Thank you, Sarah. Yes, Marfan. Marfan patients are slim and tall, right? Ehlers-Danlos, some and some, all right? But when I'm, at least for me, when I'm doing a UWorld question, for example, and I see a slim and tall patient and they mentioned it in the question stem, this is a Marfan syndrome until they tell me something else. All right. So keep that in mind. 36-year-old, slim and tall, this is Marfan's, right? Now, there's also a history of trauma, which is multi-vehicle accident. The patient has involvement of multiple organ system. How do I know that? The patient has a headache, so his brain is affected. He has loss of consciousness. Again, CNS, right? Patient has loss of consciousness, and the patient has chest pain. So there's problem up there and problems in the chest. All right. Patient is also bleeding. How do I know this? The patient has, wait, is the patient bleeding? Yeah, kind of. Anyways, the patient is tachycardic. All right. So this means it's trying to compensate for something, which is probably bleeding. All right. The patient has right mydriasis. So he has cranial nerve involvement. All right. And he has absent right lung sounds. So the lungs are affected too. So pan CT is your perfect choice. All right. It's your go-to option here. All right. What bleeding is this? Come on, don't let me down, please. Don't let me down. Yes. Yes. This is an epidural hematoma. Thank you, everyone who said epidural. Yes. See, this is a convex bleeding, right? It's a convex bleeding and it's limited by the suture lines, all right? So this is, do you guys remember what's bleeding? Don't tell me the name, just tell me what type of vessel is bleeding. The MMA, yes, the middle meningeal artery. Perfect. That's all I needed to hear. This is an epidural hematoma, respecting the suture lines, convex in shape, middle meningeal artery bleeding. All right, what is this? Let's start with A. This is A, okay, and this is B. What's going on in A? Pneumonia. Okay. Any other Collapsed lung. All right. All right. Collapsed bug. I think you meant lung, but all right. Yeah. See, you guys are right. It is a collapsed lung, and the medical term for collapsed lung is a pneumothorax. All right. So this is a pneumothorax. Now, this is not pneumonia for multiple reasons. The first one is your vital signs. There's no mention of temperature. They did not say the patient is feverish. They did not say, there's any inflammatory process going on. And there's no any collection of pus. صح يا فارس. There's no any collection of pus, and there's no any signs of edema or inflammatory infiltration of the lung parenchyma. So this is attention pneumothorax, yes. All right. You can see that this is completely black because there's air coming in, compressing the lung. All right. So this is a compressed lung. Sorry, the air is coming from the lung, by the way. It's not from outside. It's coming from the lung, coming here and then compressing the lung back. Now we're done with A. Let's go to B. What do you guys think is happening in B? I mean, why did they have to put the lines? Yeah, it is an aortic dissection. But can someone tell me what's special about this aortic dissection? I'll tell you what's special about this aortic dissection. It's involving the whole aortic arch, right? So this is the ascending aorta, and this is the descending aorta. And you can see that there's a dissection here and here. Yes, Faris, exactly. There's a dissection in both of them, which means that the dissection is involving the whole aortic arch, all right? This is what we call a type A Stanford aortic dissection, and this requires immediate surgery, all right? Type B Stanford aortic dissection involves the descending aorta, all right? While A involves the ascending aorta alone, or the ascending with the descending. So this is a type A Stanford aortic dissection, and this requires immediate surgery. All right. And yeah, this is contrast CT. See, guys, brain CT is non-contrast. Okay, remember that. Brain CT is non-contrast, but for dissection, you do contrast always. Okay, so remember that for dissection and for pulmonary embolism, you do contrast. For the brain, you don't do contrast. When do you do contrast in the brain? Tumor, yes, thank you, Faris. You do them in tumors. So the clinical problem is that the patient has headache, has mydriasis, has loss of consciousness, chest pain, all right? I don't know, he is hypertensive, all right? So differentials are hematoma in the brain, which we saw, stroke, a hematoma will lead to the stroke. A concussion won't lead to mydriasis, but it should stay on your differential diagnosis. But involvement of cranial nerves suggests that it's not a concussion only, right? Now, the chest pain, this could be a pulmonary embolism, but because this is a trauma situation, pulmonary embolism is not that common, right? So you start thinking of dissection and pneumothorax, which we both saw. So this was a really interesting case. So do you guys have any question regarding this multi-organ kind of problem? Any question regarding the modalities? Why we use this, why we didn't use that? All right. Oh, we're done. Cool. All right, so we're done with this lecture. Do you guys have any questions? Need to repeat? All right. When do we use contrast? Okay, so you use contrast when you want to look at the vasculature, you want to see at the blood flow, all right? So in the brain, you don't use it for strokes, because if you're going to use the CT in the brain, you're already suspecting that there's bleeding, okay? Which is not going to be helpful with contrast. So you don't do contrast in strokes, all right? In the brain, you use contrast for tumors, all right? Because you want to see if this mass is being vascularized or not, if there's blood vessels going to it or not. So you use contrast for brain tumors, okay? Now in the chest, you use contrast for pulmonary embolism, and you use contrast for aortic dissection, all right? You don't need contrast for pneumonia. You don't need contrast for atelectasis or emphysema or COPD or any respiratory problems. I believe the only respiratory problem you're going to need contrast for is pulmonary embolism. You use contrast for appendicitis. You don't use contrast for kidney stones. Or did you do the edema part? Oh, edema part. You're welcome. I'm going to the edema part now. Where is it? Okay. Yeah, so types of edema on CT scan. All right, let's talk about it. Wait, what's going on? Okay, so you have two types. You have cytotoxic edema and you have vasogenic edema, all right? And the cytotoxic edema, there's basically one major distinction between both of them, all right? And the cytotoxic edema, you know how there's a differentiation line between the gray matter and the white matter? Cytotoxic edema will completely obliterate this differentiation. You won't be able to differentiate between white and gray matter in cytotoxic edema, right? But in vasogenic edema, the lines between the gray and the white matter are still there. So this, let's say this is A, and let's say this is B. Which one is cytotoxic? B, yes, B is the cytotoxic edema, because you can't tell me, you can tell the difference between the white and the gray matter right here. It's all one color, to me at least, right? So this is a cytotoxic edema, and this is vasogenic edema, because you can definitely tell that this is the gray and this is the white matter. All right, so that's basically the difference between cytotoxic and vasogenic edema. Give me a second, guys. Okay, let me check the questions that I missed here. I feel like I missed something. All right, you guys have any questions regarding the cytotoxic and the vasogenic edemas? By the way, cytotoxic is what happens in infarcts, so in strokes and stuff like that. This is what you get, cytotoxic edema. But in vasogenic, it's more of tumors, abscesses, inflammatory processes. This is where you get vasogenic edema. All right. So do you guys have any questions? Great. How about we take, I don't know, can we identify fibrosis on the lung X-ray? You can't definitely say that this is lung fibrosis, but yes, you can start suspecting lung fibrosis on chest X-ray. Wait, I think there's one picture. Yeah, see? All right. So you can see, look at this. Usually the lung on X-ray is black, all right? The lungs on X-ray is black. Once you start seeing striations like this one right here, can I zoom in? All right, once you can see striations like this one right here, all right, right here, you can see kind of reticulations, it's more of like spider webs or something like that, you know? Once you start seeing those on chest X-ray, you can start thinking about fibrosis, all right? And that's why X-ray is not enough to diagnose fibrosis. You always need to move on to the next imaging modality, which is a high resolution CT scan. You're welcome. All right, so let's take a 15 minutes break, all right? And then we'll come back to finish the last two lectures. All right, sounds good? Great. All right, I'll see you guys in 15, inshallah. Let's come back at, let's make it 20. Let's come back at 4, all right? Yeah, see you guys. This should be quick, inshallah. So let's go through it. All right. So you need to understand that contrast material has a lot of problems, right? We use them readily in hospitals, especially with CTs and stuff like this. But I need you to remember that the most important correlation pathologically with contrast agents is immunological reactions, right? So anaphylaxis or hypersensitivity reactions, right? This is the most important thing. Now, the organ that is mostly affected by contrast agent is the kidney, right? Or the kidneys. They are the ones that are mostly affected by it because the contrast agents are excreted using the kidneys, all right? So keep that in mind. Now, the iodine-based contrasts, we divide them into either high osmolarity, low osmolarity, or isoosmolar agents. They can be isotonic or non-ionic agents, all right? And the number of the benzene rings. Honestly, I wouldn't dig deep into this. I feel like it's low yield, but whatever suits you, Yani. Usually we go for non-ionic or low osmolar or isoosmolar agents because they have less side effects than the high osmolality agents, all right? Now, yeah, as I said, the low osmolar contrast agents are associated with significantly lower rates of acute reactions, right? That's why we prefer them. And fatal reactions because of low osmolar contrast are relatively rare, right? Now, the most common one that we use and the most readily available one and the one that is the cheapest is the gadolinium-based contrast media. All right, and this is the one that we use mostly. It's an IV contrast. All right, I don't know if you guys need to go through this, but it's isotonic. Yeah, and basically, I need you guys to remember that there's an important correlation here between contrast and a condition called nephrogenic systemic fibrosis, right? Now, nephrogenic systemic fibrosis is an extremely rare condition that develops because of contrast media, right? And what happens basically, it's basically like scleroderma. What happens is that there's diffuse fibrosis all over the body. The body just becomes fibrotic. There's fibrotic tissue in your skin, in your lungs, in your heart, and obviously in your kidney, all right? So keep that in mind. We're going to go more into it later on, all right? Yeah, as I said, there is little or no difference in the acute reactions and discomfort. Yeah, and basically reactions to those dyes are rare, right? And it's even more rare in when regards to nephrogenic systemic sclerosis or fibrosis, right? Now, in patients, some patients have risk factors that would put them in a higher risk of developing acute reactions to contrast media. I need you guys to remember that the type of media is important, right? Iso or hypoosmotic media has lower side effects, right? Patients who have allergies, basically patients who have nut allergy, seashell allergy, whatever, any allergies would put you in a higher risk category of developing an acute reaction, right? Again, asthma, bronchospasm, and atopy, they are basically hypersensitivity issues, right? So asthma, all of those are problems with IgE and eosinophils. Basically, they are hypersensitive patients, all right? And they have association with other hypersensitivity diseases. And they are also hypersensitive to contrast media, all right? And history of cardiac or renal disease, more renal than cardiac. This is the more important, more relevant issue to us, all right? Patients who are compromised renally or have decreased renal function are at higher risk of developing reactions because they can't excrete the contrast media from their body. So the contrast media stays longer in the body, leading to a higher chance of developing a reaction. And then ages, anyone who is more than 60 or less than 5, all right? Now, most reactions will happen in the first hour of injecting the dye, but some of them can happen as fast as less than a minute or even less than 5 minutes, and some of them can happen a week from injecting the dye, right? It's not really specific, but most of them will happen in the first hour of administering the agent. All right. Now, in young people, in women, and people who have allergy or history of allergy, it's more common to get a delayed reaction. So maybe the next day or the day after, they will start having an allergic reaction to the dye. All right. The pathogenesis of this it could be either a hypersensitivity type 1 reaction or type 4 reaction. Depends on the period. If it's a type 4, it takes longer period. If it's 1, it's shorter period. But basically, think of T cell mediated and allergy mediated. So eosinophils and IgE mediated reactions. All right. Now, for breakthrough reactions are, okay, let's say you have an allergic patient, right? This patient has a nut allergy, let's say, right? You already know that this patient is at the high risk of developing an allergic reaction to the dye. So what you do to this patient is that you pre-medicate the patient. And what do I do by this? Basically, you give this patient antihistamines, you give this patient glucocorticoids, you give them steroids, you give them whatever. You give them things to suppress their immune system a little bit until you can administer the contrast, do your scan, and move on with your life, right? This is the usual, and this is usually what we do. And in most cases, this patient does not develop any allergic reactions to the contrast media. But sometimes it does happen, and that's when we call it a breakthrough reaction, all right? So wait, all right, so it develops in those already identified as being a high risk reactions. All right. So patients who have severe allergies to any substance or drug are at the highest risk of getting a breakthrough reaction, right? So remember that, it's very important. You need to counsel those patients. You need to tell them, yo, listen, you're already allergic. So if we give you an allergy inducing medication, you might develop an allergic reaction. You need to tell them what to expect. So when it happens, you told them. This basically goes through the types of the reactions that might happen. You have a physiologic reaction and you have an allergic reaction. I feel like you guys can go through this on your own, but I'll just go through some of the stuff, right? In allergic reactions, think of skin discoloration, so urticarias. Patient will be itchy. There might be some edema going on, right? Patient might start salivating and crying a lot. Not crying like emotional crying, it's just patient is lacrimating, patient might have nasal congestion. This is on the mild type. And the other spectrum, which is severe type, this patient might develop laryngeal edema and spasm and can asphyxiate, all right? I guess you can go through the rest on your own. It's pretty much straightforward, but yeah. Again, this is treatment recommendation for mild. You're going to go with a normal albuterol, what is it called? I don't know, forgot what it's called. The inhaler kind of thing, right? So you're going to give them albuterol for mild reactions. You can start giving epinephrine. When it becomes moderate or severe, right? And for laryngeal edema, you always give epinephrine, right? If the patient becomes bradycardic or his heart rate goes down, you again epinephrine. But if the patient's heart rate goes up and he becomes tachycardic, you can give atrophy, right? Again, you can go through it on your own. It's pretty much straightforward. Again, all right. So CIN is a sudden deterioration in renal function, all right? And so, as I said, the kidneys are the ones that are most affected. So breakthrough reactions developing allergy despite the pre-medication. Yes. So basically the patient is already allergic to something, all right? And you know this, so this patient is a high risk category patient. So you decide to give this patient antihistamines before you give him the contrast dye. And this should prevent any allergic reactions. But although you gave this patient antihistamines, once you gave him the contrast media, he still developed an allergic reaction. And that's what we call a breakthrough reaction, all right? So yeah, now back to CIN. It's basically when the kidneys are affected by contrast media, all right? As I said, the kidneys are the most important organ that's affected by contrast media, all right? What happens is that the patient undergoes something called acute tubular necrosis, all right? Now, acute tubular necrosis can happen due to multiple things, but in this case, it happens due to dye, and the dye becomes cytotoxic to the tubules of the nephron in the kidney, right? So what will happen is that you're going to give this patient contrast media, and then hours or days later, this patient is going to start having a deterioration in his kidney function. He's going to have an increase in creatine, an increase in serum creatine. He's going to have an increased blood urea nitrogen. The patient will have oliguria. The patient is not going to produce urine, all right? And that's what we call an acute tubular necrosis, or CIN, all right? It's a form of acute kidney injury, all right? So what will happen is that you're going to have an absolute serum creatinine increase to more or equal to 0.3. So if the baseline is 1, the patient is going to be 1.3 or 1.4. So the creatinine is going to go up. Creatinine is going to go up. Also, the patient will have a high BUN, or blood urea nitrogen, and the urine output will become reduced. All right. So that's basically acute tubular necrosis, or CIN, in a patient taking contrast media. Now, moving on to NSF. NSF, as I said, is nephrogenic sclerosing fibrosis, or sclerosing fibrosis. It's a serious, sometimes fatal disease that occurs in patient taking gadolinium-based contrast media, right? So what will happen is that you're going to have fibrosis. Basically, your fibroblasts are going to start proliferating, and they're going to start depositing collagen and whatnot, and it will initiate the process of fibrosis in multiple organs. Most commonly, it's going to be your skin, it's going to be the heart, the lung, the pleura, and so on, and obviously your kidneys, all right? It has a very high mortality rate. It's I think about 20% to 50% mortality rate in these patients, and it almost always happens in patients who have renal impairment. So it's going to be an old man with chronic kidney disease or renal failure, right? Who has or must undergo a scan that requires contrast. Days after this, patient starts having tough skin. Patient is going to have problems breathing. Patient will have decreased urine output, and that's what NSF is. All right. And so almost always happens in patients with renal impairment once they take gadolinium-based contrast media. And yeah, do you guys have any questions regarding NSF or CIN? Because those are the clinically relevant topics in this lecture. All right, fair enough. Now, wait a second. All right. So, yes, CIN can happen even if the patient is normal. It doesn't correlate to his renal function. In NSF, yes, the NSF is almost all the patients with NSF. Almost all the patients with renal impairment will have. Sorry, not everyone with renal impairment will have NSF, but almost everyone with NSF has some form of renal impairment. You're welcome. All right, so a patient comes to you, all right, and you're trying to think, do I need to test this patient's renal function or do I not? All right. And the patient renal function are not impaired, right? No, they are impaired. And CIN is acute tubular necrosis, and this patient will have an acute kidney injury, all right? So what happens is that a patient will come to you, you're going to give him or her media dye, all right? And hours or days later, this patient will have deteriorating kidney function. They will have an elevated creatinine, they'll have elevated BUN, they will stop or decrease urine output, you know, their kidney function will start deteriorating in SIN. All right. But it wasn't before giving. No, it wasn't. This is after giving the contrast media. All right. So as I said, the patient comes to you and you're trying to figure out, do I need to test this patient's renal function, or do I not? All right. And there's like some contraindications, some indications to test renal function in patients before giving them contrast. All right. So if it's an iodinated contrast agent, if the patient is older than 60, you need to test. If the patient has any history of kidney disease, you need to test. Any family history of kidney disease, you need to test. Also diabetes, hypertension, basically anything that might affect the kidney, including medications, all right? So any chemotherapy medications or NSAIDs use, you need to test this patient's renal function before giving him any iodinated contrast. Now in gadolinium agents, right? Again, 60 is the same thing. You need to test anyone older than 60, right? Any history of kidney disease. If the patient has a single kidney or donated one of his other kidneys, all right, you need to test this patient if the patient has one kidney, and diabetes and hypertension, all right? Basically, this is just pure memorization, to be honest with you. There's not much to explain here. Some more stuff to memorize. I don't think I need to go through this. All right. Other conditions that might make you start thinking if you should test this patient's function is the following. If this patient is taking an enteric contrast agent, all right, so anything by oral or through the rectum, right? Any pregnant or lactating patient, children, and patients on metformin and thyroid disease. Metformin is important because it affects the kidneys and it can lead to lactic acidosis. I think we're going to go through each one of them next. Yeah. So barium is what we use for the GI system, right? You can either ingest barium or it can be injected through the rectum, transrectally. And it's used to evaluate the GI system, right? Adverse effects and immunological reactions are rare when it comes to barium enemas and barium swallows, but they can happen. The most important problem with enteric agents is that if the patient has any perforation, the barium is going to leak into the peritoneal cavity, which can lead to peritonitis. All right. So if you are suspecting that this patient has a perforation, do not give barium sulfate or barium enema. All right. I don't think I need to go through this. It's straightforward, basically what I said before. All right. So in pregnancy and in lactation, dye doesn't really affect the fetus that much. All right. Although it's up to the mother, all right? So if the mother wants to stop lactating 24 hours after they're giving the contrast, it's up to them, all right? So it's not necessary to stop breastfeeding, but during pregnancy, it's preferable to just stay away from them, from the dyes, all right? It's preferable to just stay away from it, but it's not an absolute contraindication, all right? It's not even a contraindication. It's just preferable to stay away from them unless it's needed, all right? But in lactation, it's up to the mother if she wants to stop 24 hours after getting the dye. Again, it's up to her. But there is no any proven effect of dyes on the fetus, either lactating or in utero. Now for children, again, it's not really well studied if there's any effects on them, all right? But they do have a slightly increased reaction to dyes, all right? And NSF is also a problem in children because it's also documented in children. So it's not a contraindication to give dyes in children. As I said, metformin is a drug that may lead to lactic acidosis, all right, which can lead to renal and cardiovascular impairment. That's why it's preferable to stop metformin for the first 48 hours after injecting the dye. So you take the dye today, don't take your metformin for the next 2 days, and then you can start taking it again. That's an iodinated, I think that's an iodinated dye, right? It says here that discontinuation of metformin is not necessary after administering gadolinium-based contrast if it's in the recommended dose. Honestly, all of this is just memorization. I'm not even explaining anything. I'm just telling you guys. Now, in thyroid disease, it's important, especially with iodinated contrast material, all right? Because, as you know, it contains iodine, and iodine affects the thyroid gland. So if the patient has Graves' disease and you give the patient iodine, more iodine, this patient can go into thyrotoxicosis and thyroid storm, which can be fatal. So it's very important to consult endocrinology before giving a contrast agent to a thyroid disease patient, all right? That's it. You guys have any questions regarding the contrast material? Honestly, it's just full of memorization, you know, it's just facts that I can't really explain, you know, it's just memorization. So, but if you have anything that you need me to explain, please let me know. Yes, they do. So iodine-based contrasts have iodine in their molecular structure. That's why it's important to like be careful with them when given to thyroid patients. Should be discontinued before or after using the drug. So let's say you're taking the drug today, all right? You stop taking metformin today, all right? So just at the same time you take the contrast media, stop taking your metformin for 2 days, and then you're good. They differ from gadolinium. Yes, they differ from gadolinium. Gadolinium does not contain iodine. All right. All right, going to the last lecture. The one I hate the most. Nuclear medicine. All right. All right, so the only part here that the only thing here that requires me to explain something is probably the beta decay, all right, or the process by which this whole thing happens. But the rest of the lecture is probably a straightforward kind of thing where you guys just have to memorize. So I'll just go ahead and do that. All right. So you have an element, right? Now this element has isotopes. Isotopes it's the same atom, all right, but it just has a different anatomical number because it has different number of neutrons. All right. Now, an isotope can be stable or unstable. All right. And by unstable, I mean it goes, it undergoes decay in a faster rate. All right. So keep that in mind that we use isotopes. We use isotopes of elements. We don't use the elements themselves. So we don't use iodine. No, we use iodine 131, which is an isotope of iodine. All right. So keep that in mind. These are all, you guys can read them on your own. So in decay, what happens is that a proton decays into a neutron, all right? And it can decay also into radiation or the gamma radiation, and then it becomes a stable isotope. So the main goal of an isotope is to become stable. That's why it undergoes decay, right? So when it decays, it becomes a stable isotope. It releases radiation, and it can release particles, all right? So keep that in mind. Now, she's just trying to tell you guys how we make radioactive isotopes. I don't think it's important, but let's just go through it quickly. You have a beam. So this is your target, okay? And your target is the isotope, all right? What happens is that you put a beam on it, all right? You just expose it to a beam of energy, and this beam of energy basically ends up giving you an unstable isotope. This one right here. It also releases other particles that we discard off, but we take the radioactive isotope, which is the unstable isotope, for our uses. All right. Now on this sheet, it just tells you that, see the dark boxes? These are the stable forms of the element, right? So C12 and C13 are both stable forms of. Yeah, sure. All right, so basically you have an incident beam, all right? So this is your target, or this is your element, whatever the element is, all right? And you expose it to an incident beam, and the incident beam it contains high energy, all right? So what happens is that this target beam is going to be transformed to an unstable isotope, or a radioactive isotope, which is this one. It also secretes other particles that we discard off. We don't care about. But the end product here is the unstable or the radioactive isotope, which we will use in medicine. All right. This is all industrial. We don't really do this. All right. You're welcome. So going back to this table, see the dark boxes? These dark boxes are basically the stable ones, or the stable isotopes. So C12 and C13 are stable isotopes. All right. And the more you go to the right of the graph, this means that this isotope contains more number of neutrons compared to protons. All right. So the more neutrons you have, the more to the right the graph is. The more protons you have, the more to the left the graph is. All right. And the ones that are heavier or more, or contain more neutrons, they are called the heavy metals, or heavy isotopes, because neutrons are what adds to the mass of an atom, not the protons. Ooh. All right, so this here tells you that this line is in an atom that has an equal number of protons and neutrons, right? It's not an isotope. This is the element, right? Let's say this is iodine. All right, so it contains the same number of protons and neutrons, normal element. Now, if this, if the isotope of this iodine contains more number of neutrons, all right, if it's a heavy iodine, it decays using beta negative particles, all right? But if it contains more protons, it decays with a beta positive particle. Again, it's just all memorization. You don't not need to dig deep into this because it's a whole topic. The beta decay is just too much, to be honest. All right, I'm gonna briefly explain beta decay in a bit, but yeah. All right, so clinically, we use the following radionuclides, or the radioisotopes. We use technetium, all right, or technetium, whatever you want to call it. And it's a diagnostic. It's a diagnostic tool. It's not used for treatment, all right? Unlike iodine-131. Iodine-131 is both diagnostic and a therapeutic option. So you can give the patient iodine-131 to cure the patient from whatever disease that patient has, all right? Also, we have yttrium, and yttrium is only therapeutic. It's not used for diagnosis. So the difference between X-rays and gamma rays is that in X-rays, the X-rays originate from outside the body, all right? Then they pass through the body, then they're detected, all right? So the source is external. But in gamma rays, or in PET scans, the source of the rays is internal. We make the patient eat or drink or inject the patient with the dye, all right, or the isotope. And then the source of the rays becomes from inside the patient, not from outside, like the X-ray. And then once we get the gamma rays, we have a gamma camera, and the gamma camera detects those rays and gives us a photo, right? So that's the main fundamental difference between X-rays and gamma rays. It's the site of the source of the rays. So usually radioisotopes are not labeled. So basically what labeling means is that if I give someone technetium-99, right, without labeling it, it's going to go and distribute in the whole body. It's going to go equally to the brain, to the heart, to the kidneys, everywhere, right? Which is useless because I want to detect a specific pathology in a specific area. So what we do is that we take this technetium-99 and then we label it with a molecule that is specific to that organ, right? So that when the patient ingests the radio-labeled iodine or radio-labeled technetium or whatever, it goes straight to where we want it to go. It goes straight to the thyroid, it goes straight to the brain, it goes straight to the heart. Whatever it is, it becomes more specific to the tissue that we need to see, all right?
So let's take.
All right. Now we have three types of nuclear medicine scans. We have the planar scan, we have the SPECT scan, and we have the PET scan. A planar scan is basically the X-rays of the nuclear imaging. The label radioisotopes. I don't think so, to be honest. But she did mention them. She did put them here. So I would just remember which one is diagnostic and which one is therapeutic. All right. Now, for the planar scan, you're welcome. For the planar scan, it's a 2D scan, basically like an X-ray, all right? You get a 2D scan, and again, it's a gamma-based radiology method, all right? They're all gamma-based, but this one gives you a 2D scan. And one example of this is a bone scan, like the one you can see right here, all right? Usually a bone scan, we use it to detect like metastasis from other cancers and stuff like that, all right? And then you have, for example, another planar image is the VQ scan. A VQ scan is what we use in pulmonary embolism for pregnant ladies, all right? So usually, normally for pulmonary embolism, we use what? What do you use normally for pulmonary embolism? CT, yes. You use a CT scan with contrast, right? But if the patient is pregnant, we go for a VQ scan, all right? It's a nuclear scan. It's a planar scan, right? Now we have SPECT. SPECT is the CT scan of nuclear medicine. It uses the same gamma radiation, it uses the same gamma camera, all right? But this time, it gives you 3D images. It doesn't give you 2D. So it takes multiple planar scans and then combines them to give you a 3D scan, all right? And that's what a SPECT is. Now there's a difference between planar and SPECT, obviously, all right? A planar has improved resolution, improved physical sensitivity, so it's more specific to the organs, all right? And it's much more quicker than SPECT. So it takes less time than SPECT. It's also much cheaper than SPECT, and it's more readily available than SPECT, all right? SPECT will have a better contrast. It's more sensitive. So the smallest changes in the human body can be detected better with a SPECT than planar, all right? And it gives you a 3D view of the body. So let's use it. All right, VQ is a type of planar, yes. And when is it better to use SPECT and when is it better to use planar? Planar is your initial step, all right? So it's what you go to first. If you don't see anything on your planar scan, you move on to the SPECT scan, all right? There's no really a difference, but there's no indications and contraindications and whatnot. It's more of like an order, right? Also, there are some scans that are only SPECT and some scans that are only planar. So a bone scan, for example, can be only planar, while a VQ scan can be both. But usually it's a planar, you get me? So it's always, if you don't find something on your planar scan, you move on to your SPECT scan. All right, now we talk about PET, all right? This is the bread and butter of this lecture. And the whole process is basically what we call a beta decay, all right? Now, if a nucleus or if an atom has an extra proton, all right? What happens is that this proton has to be expelled out of this atom for this atom to become stable, right? And the atom does that using beta decay. It decays, all right? So this proton is gonna be expelled out of the nucleus in the form of three things. one neutrino, one positron, and one neutron. All right. Now, a positron is basically an electron, but with a positive charge. So an electron, we all know an electron is negatively charged, right? The opposite of an electron is a positron. So it's a positively charged electron, all right? A neutrino what can I say? All right, so you know how, I don't know how to explain it. All right. It doesn't matter what a neutrino is, right? We all know what a neutron is. The most important thing is the positron, all right? The positron is what we detect. The positron is what gives us the gamma rays in this case, all right? So it's the most important thing that comes out of the proton that we want to expel, right? So you have one proton, it's expelled out of the nucleus. It gives us one neutrino, one positron, and one neutron, all right? We use the positron to detect the gamma rays and get the image. That's basically how it goes. I want to form a way to explain what a neutrino is. I know what it is, I just don't know how to say it. We'll come back later to it, all right? So this only happens in radioactive matter that is really unstable, all right? So again, isotopes.
These two opposing types.
This basically tells you that this one nucleus, if it has more than one positive, if it has, let's say, 2 extra protons, you're going to end up with 2 neutrinos, 2 positrons, and 2 medias, right? And basically, they're going to go in the opposite direction, right? And both of them are going to have the same equal charge. Nothing really to understand out of this, is just there, all right? And the patient will be surrounded by gamma cameras, and those gamma cameras are what we use to detect the gamma rays coming from the positron, all right?
These two, now even.
This is a PET scan, right? Now, a PET scan is used to detect activity. It's not used to detect anatomical structures. What is used to detect anatomical structures? An X-ray, a CT, an MRI. Those are structural scans. You can see the heart with them, right? You can see the lungs with them. But a PET scan detects how functional the heart is, how active it is, all right? So when you put them together, you get a PET CT, right? What you're seeing right now, this is a PET scan, right? You can't really tell what the lungs are. You can't really tell where the heart is, but you can tell that this black mass has high activity levels, right?
Now, even though there was
all right. Now, this is a CT, and this CT tells you that these are the lungs, the heart is somewhere, this is the liver, this is mediation. So it's an anatomical scan. You can see structures with it. This is a PET scan. As I said, you can't see structure with it, but you can see activity. If you put them both together, you get both anatomical structures and functionality of this organ. All right. So you can tell that there's a mass in the right lung that is super active. All right. You get the activity from the PET scan, and you get the anatomical differentiation from the CT scan. Is this part clear, guys? All right.
It's now.
All right, so we have a case here, a 68-year-old female known to have breast cancer 3 years ago, presents with pain in the left hip. What is the appropriate radiological examination? What do you guys think? A mammography? All right, fair enough. Planner, a bone scan? All right, that's another fair answer. If the question tells you what is the first thing you're going to do, all right? Personally, I'll go with an X-ray of the hip, all right? But let me ask you this. What do you guys think is going on here? What is this patient having right now? Exactly, she's having metastasis from the breast cancer she had 3 years ago, all right? Now, I'll do an X-ray first, but the appropriate radiological examination would be a bone scan, all right? It's not going to be a mammography because right now, you're thinking this metastasized, all right? You're not going to know if it metastasized with a mammograph, because even if you do a mammography and you can see the cancer there, you don't know if it went to the hip, right? So you need to focus your examination on the whole body. That's why you do a bone scan. So first thing is an X-ray, all right? You can see there's a pathological fracture right here. Where is it? Right here. All right. So there's a pathological fracture. All right. But you're going to end up doing a bone scan. All right. This is your end goal. And I don't know what to say, but this patient has metastasis quite literally everywhere. If you guys see, the dark spots are areas of high activity, and tumors are highly active structures. All right. So it basically tells you that this patient has metastasis everywhere. Right? We usually use technetium-99 that is labeled with bisphosphonates. All right. So bisphosphonate labeled technetium-99 is what we use in bone scans, because bisphosphonates make up part of the bones, so they're kind of specific to bony structures. All right. Do you have any questions regarding this? All right, move on then. All right, so this is a normal bone scan. All right, now you're going to ask me why is the bladder dark? It's dark because it's excreting the dye. Also, same thing with the kidneys. All right, so you can see that the kidneys are also kind of dark. They're dark. So as I was saying, your kidneys and your bladder are going to be dark because the dye is being excreted through them, right? But this is a normal bone scan. Now you might ask me, why is this part dark? I'm going to tell you this part is dark because this is area of high activity. Your sternum and your pelvic bones are areas, and your vertebra are areas of high activity when it comes to erythropoiesis. All right, this is where blood is being made. Right, so they are going to be dark. Right. Also, when they are uniformly dark, right, this makes the suspicion less of cancer. If you take a look here, can you see how the dark areas are kind of like spots, kind of like like, you get me, like spots of darkness. This is more suggestive of cancer. All right. So any questions regarding bone scans and bone metastasis? Nope. Okay. Move on.
On the left-hand side,
okay. An 8-year-old boy is brought by his mother due to fatigue and loss of appetite. The boy has complained of repeated attacks of urine infection over the last year, slightly febrile, otherwise normal vital signs. Urine tests shows increased WBCs. The renal function is normal, what is the most appropriate radiology examination you're going to do in this patient. Let's say, what's the first line radiological examination you're going to do? Any takers? Any answers? You guys can hear me, right? Just want to make sure in case connection wasn't. All right, cool. Okay. So the first line treatment, the first line method you're going to use is probably an ultrasound. All right. You want to assess this patient's bladder, and you need to assess this patient's kidneys, right? Because the history of repeated infections is worrisome. You need to make sure that the kidneys are still fine, right? So you're going to see a scarring of the kidney parenchyma. You're going to see whatever, okay? But you need to find out what's the cause, and to find what the cause is, you need to do a planar scan, right? Or what we call a renal scan. Can we do CT with contrast? See, now the problem in this patient is that he has renal problems, all right? He has problems with his kidneys. He has problems with his urinary tract. So giving contrast in this patient is, you're walking on thin ice here. So it's not indicated, or it's preferable to stay away from dye in these patients, right? Especially patients with renal problems. Even if he's not renally impaired, it's thin ice, okay? So what we do is that we do a renal scan, okay? And so we also use technetium or technetium, whatever you want to call it, but we bind it to DMSA, all right? And DMSA is specific for the kidneys parenchyma, all right? What you're going to see is there's like white spots in the kidney. It should be uniformly dark. And the kidney should be uniformly dark. So if you start seeing white spots in it, or discolored spots in it, you start thinking of scarring of the kidney parenchyma, all right? Also, this tells you that this area of the kidney is not functioning, all right? So there's a relative decrease in the renal function, although the creatinine and the BUN are normal, there's a relative decrease in the kidney function, all right? Usually stuff that might cause this could be a vesico-urethral reflux. It could be renal scan is planar or SPECT. It's a planar scan. Renal scans are planar scans, right? Usually congenital problems are what cause, they are the cause of stuff like this, especially in patients who are this young, 8 years old with renal problems. It's usually congenital obstructive diseases. So a vesico-urethral reflux, yeah, basically, right? Cool. So case number 3 is a 27-year-old female with shortness of breath. 27, shortness of breath. What about the last image of the left kidney? Wait, let's go back. What about the last image of the left kidney? All right, so in the last image in the left kidney, nice catch, by the way, this is probably due to total failure of the kidney itself, right? This is probably not the same patient, right? Just to be clear. But this kidney is you're gonna have, if you do a normal CT scan of this patient, you're gonna notice that this kidney is smaller than the other kidney. Now, there might be multiple causes. This kidney could have diffuse fibrosis. There could be a renal artery stenosis. So there's decreased blood flow to this kidney, leading to its shrinkage and decreased function. There could be autosomal dominant tuberointerstitial nephritis. A lot of causes can lead to one kidney failing or shrinking, right? But this would be diffuse. It's going to affect the whole kidney itself, all right? While here, it's more of focal scarring. So you can see right here, you can see it right here, stuff like this, all right? We're good?
This case is a
all right. You're welcome. So a 27-year-old, right? She is a female who's 27-year-old, and she has shortness of breath. She's 11 weeks pregnant. Physical examination include lower extremities was normal. The labs, including the D dimers, are normal. The ER doctor is suspecting a PE. What is the appropriate radiological examination for this patient? Thank you, guys. You do a VQ scan, all right? You can do an X-ray, but okay. So why did the doctor do an X-ray here? I just realized it. Why did the doctor do an X-ray? All right, the doctor did an X-ray because the D dimers are normal, all right? The D dimers are normal and her cows are normal. So the suspicion for a DVT leading to a pulmonary embolism is kind of low. So they want to start with an X-ray, all right? And notice, honestly, I wouldn't do the X-ray because she's pregnant. I don't know why there's an X-ray here. Wait, let's hear the recording.
Case, the clinical problem of shortness of breath suggests different differential diagnosis. Pulmonary embolism, which is a serious medical problem, and could be then an alternative test would be more appropriate, considering the fact it exposes the patient to a.
Okay, guys. Honestly, I don't know why did she go for an X-ray here. I wouldn't. I know in the hospital they wouldn't. But the appropriate medical or imaging modality for this patient would be a VQ scan, especially that they said they suspected a pulmonary embolism, so they know what they're looking for. A VQ scan is a diagnostic procedure for a pulmonary embolism in pregnant ladies, right? We use technetium 99 again, that is labeled with microalbumin, and we give it as an inhaled substance, right? So this one is inhaled. It's not IV, it's not oral. We give it inhaled. So it's technetium 99 that is labeled to microalbumin, all right? As you can see here, guys, can you see this filling defect? You see it right here? See how this lung is fully saturated right here? It's fully saturated. But this one, it looks like there's someone who took a bite out of it, right? There's a filling defect. It's not perfused to the maximum, all right? Now you have in each VQ scan you have a line for the ventilation scan. You have a line for the perfusion scan. If the problem is in the ventilation part, this is not a pulmonary embolism, all right? This is an obstruction. It's more of an obstruction. The air is not flowing in. There's no ventilation to the lungs. But if the problem is with the perfusion part, this is a PE because the blood is not going to the lungs. Is this point clear? All right. So in any VQ scan, because, okay, so you have on this side, you have the ventilation scan, right? This part is a ventilation scan. And this part assesses the airflow from your nose to your lungs, all right? Is the air flowing or is it not? That's why it's called ventilation. On the other side, you have the perfusion scan. And the perfusion scan assesses the blood flow to the lungs. Is the blood reaching your lungs or is it not? In a pulmonary embolism, blood does not reach your lung. So the problem is in the perfusion part. Your ventilation scan is going to be absolutely normal, all right? Because you can breathe. Air is flowing from your nose to your lungs, no problem. There's no obstruction. But in your arteries leading to your lungs, there's a clot. There's a pulmonary embolism, right? Which will affect the perfusion because blood is not reaching your lungs. So on the perfusion side of the scan, you're going to find a defect, which is this defect right here, indicating that there's a perfusion problem, which means a pulmonary embolism. But you're ventilating perfectly. You're breathing in, you're breathing out, no problem. The problem is with the blood not reaching your lungs. Was it clear or perfect? All right. So you can see, guys, here that the lung looks like someone took a bite out of it, right? There's a filling defect. That's what we call a filling defect. So yeah, do VQ scan for a pulmonary embolism in pregnant ladies.
This case.
Oh, there's another case. Okay. All right. A 35-year-old female with neck swelling. Examination revealed a hard swelling of the thyroid gland. The laboratory tests are normal. The physician suspects thyroid nodules and orders an ultrasound. The aspiration confirmed a diagnosis of thyroid cancer. What is the role of nuclear medicine in this case? See, the patient, the doctor is not asking you what scan are you going to order, what mediation. What is the role of nuclear medicine in this case? Why are you suspecting metastasis? Because she didn't complain of anything other than the thyroid nodule. So at least I won't suspect metastasis yet, all right, until I investigate further. But the first thing I'm going, okay, someone mentioned using of iodine 131, and we mentioned iodine 131 is both what? Therapeutic and diagnostic. So that's that's the role of nuclear medicine in this case. We are going to treat this patient using nuclear medicine, using iodine 131, not only diagnose her. So you're going to do a thyroid scan, and then you're going to give her iodine 131 to ablate the thyroid and kill the cancer. So nuclear medicine here is not only diagnostic, it's also therapeutic. All right. So treatment of advanced metastatic thyroid cancer is iodine 131. Detection of reoccurrence using okay. So if you have metastasis and you want to detect it, you use iodine 123. All right. So let's say the patient had thyroid cancer 10 years ago, and you're thinking that this patient might have recurrence of the cancer again. You use iodine 1231, right? But iodine 131 is the treatment of thyroid cancer, right? Now, this is a normal thyroid scan. There's an equal uptake of iodine in both lobes, all right? If the patient has a cold nodule or a cold cancer, part of this thyroid is going to be white because it's not uptaking any iodine, right? This is what we call a cold nodule or a hot nodule. And a cold nodule can be cancer, while a hot nodule cannot be cancer, right? So if the patient has a hot nodule that's producing a lot of thyroxine, this is a good thing because there's a low chance of it being cancer. But a cold nodule is suspicious of cancer. All right?
This case highlights, this is
another case? Damn. Do you guys have any questions regarding the thyroid scan? A hot nodule will be black. Yes, a hot nodule will be blacker than a normal thyroid. So you see how black this thyroid is? A hot nodule is going to be even blacker than this. A thyroid scan is planar, or a thyroid scan is planar scan. So thyroid, a bone scan, they're planar scans. VQ scans can be both, but mostly they're planar. All right. All right. So a history of, okay, so a 56-year-old man with a history of coronary artery disease and myocardial infarction. Cardiac echo showed reduced left ventricular function. What is the role of nuclear medicine in this patient with suspected myocardial ischemia or confirmed myocardial infarction? What's the role of nuclear medicine here? Remember, I need you to know that nuclear scans detect functionality. They do not detect anatomical structures. They don't care about how your heart looks. They do not care how big your liver is. They care how functional the organ is, all right? Is it doing its functional or is it not? So the role of nuclear medicine in cardiology is to assess the function of the left ventricle. Is the left ventricle being perfused enough? And is it contracting enough? And is it using enough glucose or not? All right. So it assesses the function of the left ventricle. It doesn't care how big the ventricle is. It doesn't care if you have a tumor inside your ventricle. It wants to assess the function of this ventricle. Obviously, a tumor would appear also, but like you get the point. Okay. Use a VQ scan? No, a VQ scan is only for your lungs. Okay, so it's just for your lungs. So we use SPECT. I think this is a SPECT. Yeah, I believe this is a SPECT scan. All right. So what happens is that you inject this patient with a I believe this is fluorodeoxyglucose, FDG. All right. And you're going to assess how much of this does the left ventricle absorb. All right. In a normal case, this is how it looks. See how there's diffuse uptake of the glucose in the left ventricle? Looks completely normal, right? Now, in myocardial infarction, you're going to have spots where the glucose uptake is decreased. All right. So can you see this? See how this should be like curved, this like this one. Should be like a horseshoe. See? But when you stress the patient with myocardial ischemia, can you see how this part doesn't uptake anything anymore? Because its functionality decreased. It's not functioning as it should. All right? Was this clear, guys? All right, great. Hopefully this is the last case. A 29-year-old male with few months history of abdominal pain and diarrhea. The examination was normal. The labs showed evidence of carcinoid tumor. How can we localize the tumor? A PET scan, yeah, basically. Basically a PET scan, all right? You're gonna use a PET scan for tumors that are hard to detect, all right? And carcinoid is one of the hardest tumors to detect anatomically in a patient, all right? So what you're gonna do is that you're gonna do PET scan using gallium, all right? And you're going to label the gallium with octreotide or DOTA, all right? Octreotide is I think it's a serotonin analog or an antagonist. I'm not sure, it's one of them, but it has to do with something with serotonin, all right? Octreotide scan is used to detect carcinoid tumors, which are serotonin secreting tumors, all right? That's why DOTA makes the gallium specific to the carcinoid cells, all right? So you're gonna do the scan right here, and you can see that it's metastasized or it's localized in the liver, in the small intestines. You know, you can now visualize the tumor. All right. Here, the patient actually underwent. Do you guys know what's the scan? I think I showed it to you. Yeah, I think we discussed it. What is this? It's a PET CT. Yes, perfect. So it basically shows you both the functionality of the tumor and the anatomical differentiation. So you can tell exactly where this tumor is. You can see that this tumor is in the liver because you can see the liver because of the CT, and you can see that there's a hyperactive foci inside the liver, which tells you that this is the carcinoid tumor right here. All right. So for carcinoid tumors, it's gallium bound to DOTA, which is called an octreotide scan. Octreotide scan.
Nuclear medicine has a very last case.
All right. Case number 7. A 16-year-old gentleman with increased swelling of the neck and axilla. The patient has loss of weight, fever, and night sweats. On examination, the physician felt multiple enlarged lymph nodes. What is the role of radiology in this patient? What do you guys think this patient has? Cancer, right? Metastatic cancer, it could be, but this patient is 16 years old. Could be an infection, why not? But loss of weight, night sweats, more of cancer. But it could be an infection, yes, you're right. 16-year-old. Graves' disease would not cause enlarged lymph nodes. Yes, Shema. This is most probably lymphoma. He has multiple enlarged lymph nodes. He has all the B symptoms, or the weight loss, fever, night sweats. Those are what we call the B symptoms. So this is most probably a lymphoma. All right. Now for lymphoma, we have a scan for it. All right. It's the FDG PET scan. All right. And you can see it right here. You can see that there is, if you can look right here, can you see this red hyperactive focus right here? This tells you that this is a tumor, or there's some neoplastic process going on here, because there's an increased activity that is abnormal to its location. All right. Basically, you just need to memorize the name of the scan. It's an FDG PET scan. It's also, this is used mostly, it's because in lymphoma you don't really care where the tumor is. All right, you care about how spread the tumor is. So is it above the diaphragm only, or is it above the diaphragm and below the diaphragm? Because this is how you stage lymphoma, by the diaphragm. Is it above? Is it below? Basically, that's how you stage it. So we use PET scan to stage lymphoma. We don't use to treat it. We only use it for staging. Any questions regarding lymphoma? We're done. Do you guys have any questions regarding CT, regarding, yeah, we got our first question right here. So the difference between respect is function of PET. No. Any nuclear scan is for functionality, all right? Whatever that scan is, planar, SPECT, PET, they all detect functionality, all right? The difference between SPECT and PET is that PET has a higher resolution images, all right? It's like the difference between CT and MRI. You get me? They all detect functionality. This one gives you better quality images and is much more expensive, which is PET. All right, PET gives you a much higher quality image with a much better contrast than SPECT. Okay, because they all detect functionality. You're welcome. Any questions regarding this scan, the nuclear imaging, CT scans, radio, contrast, anything? All right, I think we're done. Haroon should take over when he's done with his BLS course. All right. If you guys have any questions later on, you need me to explain something again, anything at all, I'm here to help. You can reach me on my phone number, on my email, whatever you find appropriate. I'm always here to help. Thank you so much, guys, and have a nice day. See you. Bye.
So inshallah, this should be a good fun lecture. We have two lectures. The first we'll do ultrasound, then we'll do MRI. If you guys have any questions, please write down in the chat and I will check it periodically this time to make sure that we are keeping up a good pace. And yeah. So clinical applications to ultrasound. So we have already taken one lecture on ultrasound. And this focuses more on the clinical scenarios that you may get in the clinical application, right? So we covered the physics parts earlier in the pre-midterm lectures, and we also covered some of the organ systems. Now what we're going to do is we're just going to talk about the usage of ultrasound and then revise some of those clinical scenarios, and then I'll give you some points for the exam. Okay. Also, I've made some extra slides to supplement this lecture here. So we'll refer to those slides as well, and hopefully it'll make things a bit easier. So this is a PDF that I received, that's why I'm scrolling down. So the first slide just talks about different imaging techniques. So I'm sure you guys are aware by now, this is an X-ray, this is probably an MRI, this is an ultrasound, and this is a PET scan. Yeah, okay. So again, over here, he just asks, how do doctors see the patient? So when you actually are in clinical practice, you're treating the patient, right? You're not treating organ systems. So you always have to keep in mind that, you know, this person has feelings, and as cool as the diagnosis and all of the treatment sounds, you should always keep the patient in mind. So anatomists, they always focus on the anatomy way too much, in my opinion. But sure. And then radiologists just love black and white. So there we go. Okay, so then he goes some history on X-rays. So slides which aren't that important, I'm just going to rush through them because there's no point in spending time on them. So over here, there was this one physicist who basically found the X-rays. Basically, he scanned his wife's hand by mistake, and I think this is the ring on her hand, and he's really famous for it. Know the name? Yeah, the first X-ray was actually on a woman. So there we go. And yeah, just know the name of this guy and know the dates, because they can ask you questions like that. So ultrasound techniques, that's basically what we're going to focus on. So this is a normal ultrasound, and this is a Doppler, and this is also a Doppler, okay? So again, ultrasounds, how do they work? They work on the principle of sounds which are of a higher frequency than what the human body can hear. So usually we can hear from 2K to 20K hertz of frequencies, but if there's anything that's higher, then we call it ultrasounds. So it was first used for World War I to be able to detect submarines under the water, and we called that the radar system. Nowadays, it's also used by cars when they want when the police want to see how fast a car is going. This is the technology they use, and it basically works on the principle that if something is coming towards you or going away to you, if a sound wave hits that object and comes back, based on whether it's going towards you or away from you, it's going to change the frequency of the sound that was sent earlier. So the echo will have either a higher frequency if the person is moving towards you, or a lower frequency if the person is moving away from you from the original sound. And that's how they basically detected the distance of the object, right? And this is also the principle behind the Doppler ultrasound that we have nowadays. So again, any bold thing, just memorize it for the exam. It may be important. Yes, does sonar exist in nature? Yes, it does. So dolphins and whales and bats, they all use echolocation, which basically means that they produce sounds, and then the sounds which are reflected back, which are known as echoes, are detected by the same animals, and based on the changes in frequency, they're able to tell the distance and the speed of the object, where they're moving away from them or towards them and all of that. So over here again, you know, they give us a spectrum of the sounds, and then they tell you, okay, so acoustic basically means human. So the human ranges from 20K to 20 hertz to 20K hertz, usually. And then animals have a bit better hearing than humans because they can cover a bit more, and that's why they're able to use ultrasound, which humans cannot. Some animals have better hearing, and then we have the ultrasound that we have that we use in the medicine, right? So again, this is just for you guys. I don't think they would ask you anything on this. Again, cute pictures. I'm assuming he had sounds when he gave the lecture. Okay, so now we start with our basic topic, right? So we're done with 10 slides in like 2 minutes, cool. So what are the pros of ultrasound? So one, it's universal. Universal, either it can mean that ultrasound is the same throughout the world, and secondly, it's also widely available. So in a country like Pakistan, where you don't have a lot of healthcare national coverage, you would still find ultrasound even smaller hospitals, because it's very cheap and it's easily accessible. Which brings us to our second point, which is cheap. So you don't need a proper room to maintain an ultrasound machine. You don't need to have a certain temperature. You don't need a lot of electricity to run it. You don't need specific requirements like having the AC on 24/7 to run it, So even nowadays, you can just have an iPad plugged to a transducer and you call it ultrasound. So it's really cheap. And it offers you a wide experience. So in other imaging modalities, you just get a static image. But in this case, you actually see the organs moving when you're doing it at the bedside. If a person is breathing in, you can literally feel or you can actually see the liver moving when you ask them to breathe in versus you ask them to breathe out and stuff like that. If you can't see a clear view, you can ask the patient to turn around, or you can get a better view, put the transducer or something else. So it's really, offers a wide range of experience. And then you can also have multiple number of organs that you're looking at. So, we'll talk about this later, but you have a wide variety of organs that you can look at. And there's no delays in scheduling. So for example, in KFSH, if you order an MRI, if it's not urgent, they won't really give it to you until maybe a week later or so, because there's only so many MRI machines in the whole hospital, maybe like 1 or 2 in a very fancy hospital. So it always has scheduling and then delays and all of this. Whereas for this device, again, it's handheld. You can literally walk around with it in the emergency room while taking history, or doing physical exam, you can do this. And it's kind for the patient. So kind for the patient in the sense that it takes really little time to be able to operate it. Versus, for example, an MRI machine, which takes around half an hour for the procedure. You don't have to be fit into one particular room and there's clunking noises and all of that. So it's really good for the patient as well. It's a brief procedure. You just have to apply some gel on it. They may feel a bit cold, and they don't have to either, some procedures you have to ask them to, okay, you need contrast. So are you allergic to this or not? Can you do this or that? Some requirements like you don't have to eat for so long and so on and so forth. So generally you don't have those in ultrasound. But what are the disadvantages? So it requires experience because, it's really operator dependent, and it really depends on your experience or how familiar you are with the surroundings, because the anatomy of every human being is different. And then when they are sick, it's even harder for you to, spend time on looking at the structures, because the patient is in pain and you want to, not put them in more pain. And then obviously the other con is that there's always limitations. You can't really see the deeper organs for complex cases. If a person is obese, you may have difficulty in viewing the organs which are underneath, and so on and so forth. So these are some of the pros and cons, okay? They can ask you about these, so these are important for the exam. Okay, what do we need to operate on an ultrasound machine? So as I said before, you probably need a bed. Even if you don't have a bed, it's fine, but you need the machine. So this machine nowadays, you can just have it on your iPhone or your iPad connected to it, and that works as well. But usually you need this machine. As you can see, it's also portable, so you can just move it from room to room. It needs some sort of electrical power for charging, and then you can even remove the wire and then just move it around because the battery just charges up. You need a gel to be able to help the sound waves travel through from the transducer to the body without a major fluctuation. So you want to decrease the amount of reflection at the skin. And then you need obviously an interpreter, and yeah, that's the interpreter. I don't know what this is. So talking about ultrasound, it uses sound waves to produce pictures inside the body. Okay, cool. Okay, So now what are the uses? And I think this is the most important thing over here, because the questions that you're going to get in the exam are mostly going to be scenarios, right? And for second years, it's actually really difficult to be able to understand or make sense of the scenarios, because you haven't taken the major chunk of the pathologies, right? So if this course was in third year, we probably wouldn't even need a radiology crash course. But for you guys, I think it's really important just to be able to keep these conditions in mind. And if you get a question which fits one of these, then you know which modality we will be leaning towards, right? And I'll talk about this more in the next lecture, okay? So what is ultrasound used for? It's used for diagnosing pain, swelling, and infection. And we have slides later on which tell us more about this. And then you can also diagnose the fetus. And this is a major use of ultrasound in OB-GYN. And in infants, so infants, as we know, they are young and they cannot be exposed to ionizing radiation, right? They can be exposed to MRIs because we haven't had any solid evidence that they cause harm. But then again, MRIs are really, really expensive and take a lot of time, and you can't really ask children to stay in one place, right? So for some stuff, like some organs, like the brain, the hips and spine, they use ultrasound for infants. So the question arises, how can you view the brain when it's surrounded by the skull? So for infants which are, just developing, they have two fontanelles, an anterior and posterior fontanelle, and the interior fontanelle doesn't really close until, I think, I'm not mistaken, 12 months to 18 months. So you still have like a tiny opening in front of your head or on the top of your head. So they can place the ultrasound over there, and then they're able to see parts of the brain. And they're able to rule out major, problems in case there are any. Hips. So in children, sometimes they can have this condition which is known as DDH, developmental dysplasia of the hips. Basically, there's a problem with the development of the hips, and they're not aligned with each other. So what people do is that they use ultrasounds, because in children, again, the bones still have some space between them. So what they do is they try to check the distance between various parameters and see if the hips are dislocated or not. And then the spine, again, they want to rule out stuff like, meningocele or spina bifida, all of those fancy stuff that you studied. So it's basically a problem where there's a break in the spine, right? So if there's a break in the spine, that means the bone won't be present over there. So they can use an ultrasound to check if there's a problem or not. So I added a couple of extra slides to help you with this. Let me switch my screen over to that. Let me see if you guys can see my screen. Okay, so this one is a hip ultrasound, and this is basically the head of the femur. Right, so they have these different parameters that they measure, and they're able to make out stuff, and then they know if it's displaced or not. Okay, you don't need to know the details. Even I don't know the details. Gluteus is basically the muscles of the hip. So this is from the top. So they place the probe over here, and now we're looking down. The second picture is that of a child. So this is the spine of a child. You can see that this is still a fetus, right? So it's still inside the womb of a mother. So we can actually make out all the spinous processes, which are dark over here. And then you can actually make out the spinal cord over here. And if there's a problem or something, it would appear abnormal, okay? So that's just to give you a better idea. Okay, so we're done with this slide as well. Okay, it helps guide biopsies, diagnose heart conditions, and assess damage after heart attack. So we'll talk about these in the next upcoming slides. So again, ultrasound is safe because it does not use ionizing radiation, which does not cause damage. It uses ultrasounds, which are generally safe. It's non-invasive, so you don't have to you know, you don't have to ask the patient to drink some contrast or something like this. And you don't need any expensive procedures, get them to the operating room or something just to be able to carry out this. It does not use radiation, again, it's safe. Needs no special preparation, so we talked about this. You should not eat or drink beforehand. So this is probably the only thing that sometimes is needed. For example, if you want to, an example right now. Sometimes, let's put another example that I can remember. So sometimes if you want to get an ultrasound of the bladder, you ask the patient to drink a lot of water, you know, so I'm guessing similarly, if you know, sometimes you would ask the patient not to eat or drink beforehand, but I'm not sure about the specific conditions of when they would ask this or when they would require this. Actually, I think with these slides, yeah, okay, let's put it that way. So leave the jewelry at home because, you know, some jewelry may obstruct the images from being formed just because they're made of metal, you know, or they may be lost when you're wearing them and putting them back and stuff like this. Wear loose, comfortable clothing because you may have to expose the organ that we're trying to see. So, you know, just wear comfortable clothing that you can easily take off and or remove part of it. For example, I want to see the abdomen, so just remove your shirt upwards. Don't wear like a thobe or something, you know. Or even that, you know, just make yourself as comfortable as possible, and then you may need to change into a gown in case we're not getting enough exposure. All right. Okay, so now we have ultrasound. Yeah, so conventionally, this is the type of image you would see. It's a 2D image, but you know, some fancy centers, they also have a 3-dimensional image, so you can actually see the shape of the baby, the actual face of the baby and stuff. This is high definition. I think this is mostly used in very, very expensive places, and it's just used for research. I have not at least seen centers which have this capability yet, because it's not really needed, you know, or it's needed for very few specific conditions, which doesn't justify the cost, I guess. Okay, so moving on to the second imaging modality, which is the Doppler. So it evaluates the movements of materials in the body, allows you to see and evaluate blood flow. Okay, so the most important thing about the Doppler is that it's able to detect movement. So anything that red, it means that it is coming towards the probe, okay? And anything that's blue, it means that there's movement away from the probe. So if, let's say the probe is over here and we see this area as red, that means that this blood that was present here, by the way, this is a blood vessel, in case you don't know. So the part of blood which is traveling in this direction is going to appear red. And the part of blood which is traveling in away from the probe, like this way, is going to appear to be blue, right? And it's a common question. They ask you, okay, so what is red and what is blue? And then people mistake it for arteries and veins. No, this is probably just one artery, okay? And it has different blood flows through it. So, and again, it's not blood flow through the artery that we're looking at over here. It's blood flow either away or towards the probe. Okay, so that's really important to keep in mind. Then he talks about the different types of Doppler ultrasound. So you have a color Doppler, which is basically this. And it arranges it into an array of colors to show speed as well as direction, okay? So generally, the brighter a color, the faster the blood is flowing, you know? So this is color again, and this is power. So power is more sensitive, and it gives you greater details. So for example, if you have, I'm sure you've heard of atherosclerosis, right? It's basically a condition in which there's plaque building up on the arteries, inside the inner surface of the arteries. So if you have atherosclerosis, you can have blood flow which is flowing faster, right? So in case the blood is flowing faster, you don't really need a color Doppler would be enough, right? But in case where blood is accumulating, like for example, ovarian torsion or something, the problem in ovarian torsion is that the blood vessel which is supplying the ovary twists around itself and it kind of blocks that blood vessel, you know? So the blood starts accumulating and it cannot leave the ovaries. Why? Because the veins have a thinner wall, so they're easily compressed when the ovary flips on itself, right? Basically, the blood does not escape the ovaries, and if in this case, there's a very slow blood flow outside. A color Doppler, we may see it with a color Doppler, but if we still suspect, that there is an ovarian torsion and we cannot really tell from a color Doppler, we may use the power setting. So in case there's a minute flow in blood, it'll still be able to detect it. So basically, these are just different settings. It's literally a touch of a button on the ultrasound machine, and you can switch them around. Okay. Spectral Doppler is something else that is sometimes used. So in this case, it forms the spectrum type of thing, and anything that's up means that it's flowing towards the transducer. Anything that's below means that it's flowing away from the transducer. So if you see this to and fro, this is basically blood is going in pulses, right? So sometimes it's moving towards the transducer, and then when the heart dilates, goes back and stuff like this. Yeah, so you see distinct with sound that can be heard with every heartbeat. So basically, you just need to know the names. And if you see these pictures, you should be able to tell if it's color or power or spectral, but I don't think they would ask you about the different uses and clinical applications of these at your level. Okay, so then it talks about aggressiveness.
Haroon?
Yes.
Sorry for interruption, but there are questions in the chat.
Okay, let's go over questions. Sorry. Blue is the only way, or can it be obstruction? Can you repeat when to use each type of these Dopplers? No, I'm not going to repeat that because you won't be asked. So a color Doppler, you can sometimes, it's to assess blood flow, right? So for example, if you're, again, example, so if you're suspecting DVT, right? So DVT basically means that there is a clot in the blood vessel and blood isn't flowing, or it's slowed down because of the clot, right? Or it could be speeded up because of the clot. Either way, you want to know if it's regular or irregular flow. So if you see this type of red flow over here, or this red flow over here, it's most probably regular flow, okay? But if you see this type of flow, that means that there is some turbulence. Something is blocking it, that's why it's not flowing smoothly anymore. So some blood is moving towards the Doppler, towards the transducer, some blood is flowing away, and you can see that there is turbulence or disturbance in blood flow, right? So that's why we use color Doppler. Now, the second thing I said was power Doppler. So let's say that this is a blood vessel in which the blood is flowing very slowly because of some obstruction downstream. So if it's too slow and we can't really appreciate that much color difference or that much turbulence, I don't know where turbulation came from, we may use a power Doppler, okay? It's more sensitive to changes in blood flow. So think of it as like being better than a color Doppler in some circumstances, okay? Especially when there is low blood flow. Or by low blood flow, I mean very slow blood flow. Spectral Doppler, I'm not exactly sure where it's used, but it gives you a spectrum of this image. Over here, this is the liver. And I think they're trying to rule out if there is an obstruction in the IVC, which is not allowing blood to flow out of it or not. Okay, but I'm not sure exactly. Okay, and yeah, sometimes it can also give you the distance traveled per unit time, which is basically equal to the speed. So yeah, a spectral Doppler, it also gives you, so there's two things, right? Either if the blood is moving away or towards, and we don't really care if it's moving away or towards, we care if there is a turbulence or not. And the second one is how fast it's moving, right? So color Doppler is good for away and towards, and power Doppler is more effective for how fast it's moving, either away or towards, right? It gives us more about the power. And a spectral Doppler, it displays both, but it displays it as a graphical image. Does that answer your question? Okay, great. If there's any more questions, yeah, just remind me in the chat because I'm not using two devices this time. Just because I felt like last time it was a bit too slow, and then people who are watching the recordings have problems sometimes. So, make it easier for everyone. Okay, so echographia. So this is an Italian word. It means echography. So basically it means ultrasound, which is this. this is RM. I really don't know what these stand for, but this is probably risk management. So he's basically telling you how aggressive are we in these techniques, or what do we use it for, I'm guessing. So sometimes you use it for diagnosis. Sometimes you use it for risk management, which basically means you want to stratify. So for example, I make a diagnosis of, let's say, a meniscal tear, right? But I want to know if it's, how bad is the tear? Is it grade 1, 2, 3, 4? So you sometimes use it for risk management. You can use it for treatment, and we'll talk about this. For example, if you want to do a needle biopsy or something, that's more towards diagnosis. But if you want to, let's say you want to aspirate assist, it helps guide the needle, and we'll talk about it. And I think this is treatment as well. Honestly, I'm not sure. RX. Yeah, so basically what they mean over here is that you can have a number of uses for the ultrasound. You can use it for diagnosis, you can use it for treatment, you can use it for risk stratification, all of that. And also you always have to weigh the pros and cons and the cost effectiveness versus the benefits versus the harms, right? I think that's what the slide means. Honestly, I don't know what TAC means. RX, from what I remember, actually, let me check it real quickly. From what I remember, it meant reaction. So that doesn't fit here. It's probably treatment. No, medical prescription. Cool, RX means medical prescription. I don't know what that means over here. Okay, so we use ultrasound to evaluate the following. I think this is probably one of the most important parts of your lecture now. So, this is where you want to pay attention. So you can use ultrasound to evaluate pain, right? So the example they gave you over here is appendicitis. Now, the first thing you need to know is that if a person has appendicitis and they ask you what is the best imaging modality, it is not an ultrasound. Okay, the best imaging modality is usually a CT. And I'm sure Maklad covered this. But in some cases where you cannot use a CT, like for example, a patient is pregnant or if it's a child and you're suspecting appendicitis, then you may go for an ultrasound. Okay, so appendicitis basically means inflammation of the appendix, and this portion over here, this tiny portion over here is the appendix. Sometimes it gets inflamed due to an infection or something. And when it gets inflamed, it causes a lot of pain, okay? So you need to be able to recognize keywords in the question stem. And usually the keyword for this is right lower abdominal pain or right lower quadrant pain, something like this, along with nausea, with vomiting, patient cannot eat, he's in intense pain. Anything like this, which is lower right, it's usually going to be appendicitis. There is one more scenario, which is known as ectopic pregnancy, which may mimic this, but I hope they don't ask you about this. So ectopic pregnancy is basically, it presents similarly, and it's due to a person who is pregnant, so obviously it's going to be a female patient, and the fertilized egg or the baby, let's say, is not in the uterus itself, it's somewhere outside. It's either in the oviduct or the ovary or somewhere else, So basically, since it's not in the uterus, it can cause pain. If it's on this side, it can cause right upper, lower abdominal pain, okay? But usually what they're going to, what they mean by right lower quadrant pain is always going to be appendicitis. So this is basically an inflamed appendix. So you're looking at a cross section. So they're cutting it like this. Imagine a tube is cut like this. So what you see is a circle, and this is the circle that you see. And this is known as a target sign because you can see like this dark thing, and then there's a ring around it and a ring around it again. So it's called known as a target sign. And it can be used in to diagnose appendicitis, but the gold standard is always a CT. Okay. Yeah, so that's about it for this. So just remember the scenario and just remember this picture. If you see this, it's probably an appendicitis. Okay, so ultrasound can also be used for evaluating swelling. So the example they gave you is goiter. Goiter basically means swelling of the thyroid gland. It can happen due to a number of problems, but either way, the problem is that there is a swelling of the neck, right? So this over here is a normal thyroid, and this is, let's go over here to give you a better example. So this is the thyroid, right? So it's basically a structure, a gland which sits in front of the trachea. Trachea means the food pipe, right? So it sits right in front of this. What they're doing is they cut it like this and they're shortening it too from the top, right? So over here, this is the trachea and this is the butterfly-shaped organ. And you see, like, you know, this is the head, the butterfly, let's say, or the body of the butterfly, and these are the two wings, right? So this is basically the normal thyroid. Now, if we look over here, this is the normal thyroid again. Now, hopefully it makes more sense. And this over here, so this is the trachea, which is supposed to be this thing over here, and now it's all swollen and wiggly and wobbly, right? So the reason why we can evaluate the thyroid using an ultrasound is because it's just present very superficially in front or right behind the skin, right? So if you put an ultrasound probe, you can pretty much make out what's going on over here. Whereas if it was a deeper structure, let's say in the esophagus or something, then there's a lot of things blocking the way, right? So you can't really see it with an ultrasound. So swelling can be evaluated using an ultrasound. Okay. Any questions? Yes, CT, thank you so much. So upper picture is abnormal? Yes, exactly. Upper picture is abnormal. This is goiter. Goiter basically means swelling of the neck due to thyroid problem, okay? So this, we see, I'm not sure what it is, and you don't need to know what it is, right? It could be, you know, just an expanded and overworking. There may be overproduction of the thyroid gland, which causes it to expand, or you've studied puberty. Okay, so it's probably hyperplasia, or it could be any other diagnosis. Either way, we can figure out what's wrong with it. We know it's abnormal, right? So again, if this image comes and this image comes next to it, or this image comes and then they tell you the patient has swelling or something, you should be able to know that this is goiter, and you should be able to know that the thing that we use to assess it is an ultrasound. Okay, the third thing is infection. So this example over here is an example of an abscess, right? So it says over here subcutaneous abscess. So what is an abscess? I'm sure you took it in POD, but quick crash course. An abscess is basically an infection. So basically that means bacteria, usually bacterial, or it could be any other pathogen that has been walled off by the body's immune system. So it's just present in this one concentrated space, okay? So much so that it can cause a swelling and redness and cause a fever to the patient. So again, if you have a patient who has fever, who has red swelling in somewhere, and you know, when you touch it, it hurts, it's tender to palpation, you know, anything like this, and they give you a scenario like, you know, picture like this, it's most probably an abscess. Now, a question for you. Why is this an abscess and why is this not a cyst? So if you remember previously, in the pre-midterm lectures, when we talked about the cyst, we said it's fluid-filled only, whereas an abscess has a lot of other material as well, right? It has a lot of white blood cells, has lots of debris, foreign material, whatever. So pathogens. So this is not really only liquid, it has solid components to it as well, right? So this is why we are saying that this is an abscess. Also, it's really close to the skin, right? So that's another indication that it's probably an infection of the skin. Subcutaneous means right below the skin. Okay, and it's usually caused by staph or streptococcus, okay? So again, these are some clinical applications of an ultrasound. So we didn't talk about the heart. I'm sure there's a slide coming up for the heart and blood vessels. So basically, the place where they use an ultrasound for the heart and blood vessels is known as an echo. Okay, it's called an echocardiogram. And over there, the Doppler and the ultrasound plays a major role because you can see the movement of the blood. You can see if there's any abnormal turbulence or not. You can actually look at the valves and you can actually tell if there is you know, a mass on them or they're not opening or closing properly. So it's really, really useful for an echo. Pus accumulation, exactly. Cyst is very black, yes. Lighter color under the abscess, yes. So there's lighter color because there is some sort of solids. Very nice. You guys are epic. Okay, so Liver, usually we use an ultrasound. We can use other modalities as well, but you can also use an ultrasound. Gallbladder, this is classic case of cholecystitis that we talked about earlier in the previous lecture. And, so basically GI systems and urinary systems or renal systems. Pretty sure it's called something else. Anyway, and then also the fetus. So it's, again, in clinical practice, OB-GYN is going to use a lot of it. GI people are going to be using a lot of it. Cardiac people are going to use echoes a lot. And then the ER is going to use it as well because it can be used at the bedside. Okay, we can also ultrasound the eye, which is very useful in some situations. So OPTHA uses it as well. Again, thyroid, we just talked about the goiter, it could be used. Scrotum, again, so the testes are very superficial as well, right? They're really close to the skin. So again, you can use an ultrasound of the testicles to see if there's a mass or something like this. Okay, and lastly, we talked about this briefly. So brain in infants, why? Because there is a fontanelle. So there's really a bones because the bones are forming. And that gives you access to the skull of the infant. The hips in the infants, I showed you a picture of certain conditions in which there is a dislocation or developmental disorder, so you can probably tell it. So in infants, you can see it. Again, so the femur is relatively very close to the skin, right? So you can get some information about these structures around it. And again, the spine and the vertebra, they're very, very close to the skin, right? So ultrasound is useful for superficial or relatively superficial organs, right? Again, moving on. Do you have any questions so far? Second check to see if we're keeping up. Am I going too fast? Am I going too slow? See, the thing is, I think I explained in a lot of detail in the previous lecture, the one pre-midterm. So if you want me to repeat anything from there, any specific concepts, sure, I would. But otherwise, I think that this is just clinical applications. So we should focus more on the clinical scenarios. Okay, cool. All is good. Cool. So this is classic cholecystitis. Now, remember how in the previous lecture we had cholecystitis. Cholecystitis is inflammation of the gallbladder, and usually it's due to the presence of a stone which is blocking the neck of the gallbladder. And when this stone is blocking the neck of the gallbladder, there's bile is being produced and a lot of fluid is being produced, and then this fluid can't move around, so it's infected by bacteria and other stuff. And then once it's infected, it has inflammation going on, and then the whole area is swollen, and then there's edema around it, and then it hurts really a lot. Sometimes you can see stones, extra stones in the gallbladder itself. It's a pear-shaped organ. The classic signs are right upward quadrant pain or epigastric pain. They can also bring it like this. There's usually fever, and it's very, very painful to touch, right? So you may have heard of or seen Murphy's sign in one of the lectures. Basically, if you touch the gallbladder or this part of the person while you are performing a physical examination, it hurts a lot, and the patient reacts to it and moves, backwards in pain. So, you can also do a similar test known as an ultrasound Murphy's sign, I think, something like this. Basically, what you do is, instead of touching with your own hand, you touch with the ultrasound probe. So you know exactly, okay, I am at the gallbladder, and then the person jumped up, so that's even better to diagnose cholecystitis. Again, so over here, what you see is, this is the pear-shaped organ. You see that there's lots of slides. So this is material which has been accumulating and can't really leave. You see these solid, brighter things, which are probably stones. You can tell these are stones because they have some sort of shadowing behind them. So yeah, acoustic shadow is there, and then the gallbladder wall is thicker than usual. So yeah, this is a classic question, and it's asked many times. Then we have the liver. So NASH basically stands for non-alcoholic steatohepatitis. Basically, it means that there is hepatitis or inflammation of the liver due to, not due to alcohol, so non-alcoholic. Okay, great. Steato means due to fat. So it's basically accumulation of fat in the liver, which causes inflammation, which leads to the liver not functioning properly, which leads to inflammation. Okay, so this is an image of the normal liver. What they're trying to tell you over here, this is a normal liver, and you can compare this image to this image and see that this is very, very messed up, right? So this is an image of cirrhosis, and cirrhosis is basically when it's like the end stage liver disease, right? So there's a lot of fibrosis going on, the liver is shrunken, it looks bad, it feels bad, and we know that it can't function properly, right? So this is an image of cirrhosis. So there's a lot of fibrosis going on, and then it can't function and it's shrunken. So this is what they're trying to show you over here. So if you can recognize the normal, you can definitely tell this is not normal, right? You can say it's an irregular border, it's shrunken, there's a lot of distance, and then there's, you know, there's nodules all over it, which is due to the fibrosis. And then over here again, so this is the liver. This is the liver again, so it somewhat looks normal here, looks normal here, and then over here there's a mass, right? You can tell it's a mass because, you know, it's heterogeneous. It has different white and black colors and grays in between. We know it's not a cyst, and we know that there's no posterior enhancement, so it's probably not a cyst. And yeah, so one more thing about NASH is that in NASH, usually what we do is we compare the liver and the kidney. So if the liver and the kidney, you can tell them apart clearly, that means that the liver is normal. If the liver and kidney, you can't really differentiate from where one starts and one ends, they're almost the same color, then that usually means that the liver is damaged or has NASH going on. So in NASH, basically there's inflammation and the liver appears lighter than usual. It's not as dark. And, you know, there's inflammation going on. But also it's still functioning. It's not like it has stopped functioning, you know? So let's say, like, if NASH continues to proceed, it will result eventually in cirrhosis. Okay, let's put it that way. So again, ultrasound is also used for the liver. And then we have kidneys, so kidney stones, we talked about this. So basically there's a stone in the kidney, which is not allowing extra urine, which is produced to exit, and then it's going to have accumulation of urine all the way here, which is going to lead to hydronephrosis. So hydro means water and nephrosis means in the kidneys. And sometimes in an ultrasound, I don't know how they got this picture, but this is amazing. You can actually sometimes, very, very rarely, you can actually see the obstruction, which is a stone over here. So this is a really good picture. Okay, so the uterus and ovaries. So let me show you the other picture. Okay, so this is what a normal ovary looks like, right? It's a ball-like structure, an ovalish type of structure, and it may have these fluid-filled cavities in them, and these are not cysts. These are normal developing follicles. Okay, how do we know they're cystic? Whether the patient will have a problem, or there's going to be protruding around or something like this. But you know, like from 2 to 6, I forgot the exact numbers, but if it's not a lot, it's probably not a problem. Okay. There's something known as polycystic ovarian disease, and over there it's just massive, just all over the ovary, and you can tell, okay, this is something is wrong. Okay. So over here, this is probably a teratoma. Basically, it's a type of tumor. Could be some other tumor, I'm not sure, but you can tell that there is something wrong with the ovaries, right? This is the circular thing, and then there's inside it, there's a mass, right? So this is probably something wrong with it. Over here as well, this is the ovary, and then you can see that there is this irregular circular thing, which is not only fluid filled, but also has other material in it. So this is an example of an ovarian tumor, borderline because it's like close to the wall, I guess that's what they mean. Either way, again, I said it's used a lot in OB/GYN, and this is one of those examples. In the gallbladder, the lighter color is stones, and the darker color, what is the darker color? In the gallbladder. Okay, so darker color over here, and this is just fluid, right? Because sludge is not fluid, but it's like the semi-solid type of state, or it's like really thick fluid, right? So that's the difference. Yeah, it's normal. Remember how the gallbladder produces bile? So bile is fluid. So this is the normal. Yeah, this is the normal how it's supposed to look like. Normal appearance of the gallbladder. Okay, so now this over here is basically OB. Okay, so OB means obstetricians, which basically means anything that has to do with a pregnant person, right? So over here, this is in the first week. So this, we're basically looking at the uterus, and again, we're placing the probe in front of the patient like this, like this. So basically, what we're looking at is a cross section of the uterus. So sometimes in week 1, if a patient feels that they're pregnant or they come to the hospital and you want to check them up and see if everything's okay, you would just do an abdominal ultrasound and you would see a uterus, and then you would see this. So this is basically a fetal pole and a yolk sac. Basically, this is the embryo inside, right? And this is important because when ruling out ectopic pregnancy, so what was ectopic pregnancy? It's basically pregnancy which is not present inside the uterus, right? It's somewhere outside. So once we see this, we are reassured, the patient is happy, everything is normal, the patient goes back happy, you know? This is in the later, I think this is the 3rd trimester, so you can actually see the whole shape of the baby, something like this, but you know, can't be as cute as this. Again, so you can tell that this is the shape of the baby, and this is the uterus, and then this is a very big baby, so it's about to be delivered. You can actually see the bones over here as well, and you can probably somewhat tell of the entire shape of the baby, right? And once they do an ultrasound of a baby at this age, they can actually see all the features which are well defined. Okay. So, any questions so far? Do I have any other slide to explain? Yeah, okay, so again, you know, in week 1, there's going to be a gestational sac, there's going to be, you know, this uterus, and then inside it, you see this tiny circle and a ring type of appearance, you know, a dot and a circle, which is basically the embryo and the yolk sac. You don't need to know the details, it's just get yourself familiar with, if I just see this one image, or no, this one image, or this one image, if I just see this one image, can I tell which organ this is? That's good enough. And can I tell which imaging modality this is? You know, that's enough. Clinical applications of ultrasound. Okay, so over here it says guide procedures such as needle biopsies, in which needles remove cells from an abnormal area for testing. Okay, so basically a biopsy, if we have, for example, a mass and we're not sure which is it cancer or not, or which type of cancer this is, or if we have a cyst and we want to know what type of fluid is inside it, right? We carry out biopsies. So usually for the thyroid and for cysts and stuff, we usually use, if we can approach it from the, if it's, you know, nearby, we can just approach it using a needle. And when that is happening, or actually biopsy of the breast as well, you know, all of these are superficial structures, right? So what we do is we take an ultrasound machine, also for nerve blocks. So the example over here is of a nerve block. So basically we take the ultrasound machine and we insert the needle. And while we are inserting the needle, we look at the ultrasound to see where exactly our needle is going. And we can, remember how I said it's a dynamic process. If something moves, you can actually tell it's moving. So you can actually see the needle going, and you can make sure that it's going in the right place, right? So over here in this example, what they're trying to do is a nerve block. So they basically want to block the brachial plexus, because you've taken this before. And the brachial plexus is located between the, this is sternocleidomastoid, this is AS, anterior scalene, and this is middle scalene, right? So what they're trying to do is they're trying to go between this to target this structures here, and basically deliver the anesthesia over here so that the patient does not feel any pain. Cool, this was a very, very straightforward lecture. This was very simple. I tried to focus more on the clinical aspects. And yeah, do you have any questions? Anything? Was I going too fast? Would you like me to go slower in the other lecture, or do you want me to speed up? Please let me know in the next 1 minute, and let me know if you guys want to have a break or continue moving forward. It's going to be, why do we not have an acoustic shadow after the gallstone? We do have a shadow, it's not very clear, I think. Yeah, it's not very clear. This is probably the shadow for the stone, right? This is probably the shadow for the stone, but it's not really clear. Yeah, you're right. And again, you know, the stone isn't really near the boundary, right? It's somewhere in the middle. So maybe it doesn't have a shadow. In the ovary slide, why is there a difference in the color of both lectures? In the ovary slide, why is there a difference in color? That's a really good point, actually. So you mean between this and like this one as well? That's a good question. Actually, I'm not sure. Maybe this is. See, sometimes when you have a problem with the ovary, sometimes you have a lot of fluid inside the abdomen which keeps on building up. So it could be that there's a lot of fluid around, and this is why we see it like this. But I'm honestly not sure. Over here again, this is definitely the ovary, and then there's this problem. But I get your point of confusion. Honestly, I'm not sure. Maybe this is the whole mass that we see. There's the picture of. Either way, we know black is fluid, right? So this is not the ovary. Wait, never mind, wait. This is the ovary for sure. This is the uterus, because it says uterus over here. It says uterus over here. And so the uterus, it usually appears like a rectangular structure or like a trapezoid structure. So yes, this is a uterus. And this is a mass in the uterus. Nice. Yeah, so it's dark because this is the uterus, right? So the uterus is usually empty. So it's going to be either, see, I don't know if there's air or not. I know it's empty. It could be fluid, it could be air. Either way, it's black. And then there's this mass over here. You know what? Just let me try to show you a picture of a uterus. Let me search uterus. See, this was the problem. The uterus has different views. Okay, this one's oh my God, that's bad. Yeah, uterus has different views, and this is not the best view at all. Okay, let me show you guys. So basically, see, this is what a uterus usually looks like. This is what a urinary bladder usually looks like. So over here, not here, over here, this over here is most probably a uterus. Sorry, it's most probably a bladder. This is my thinking. I think it's a bladder. Your doctor mentioned uterus. I don't know why. And this is why I was like, it's usually black, so it's probably the bladder. You know, that was my logic of thinking things through. So yeah, in my opinion, this is a tumor of the bladder. But yeah, because a uterus, either it looks like this, or if you're looking at a different view, it looks like a circular thing that we see over here, this circular view, right? So either it's this view or it's this view. And even in this view, if you see, there's a very thick wall of the uterus, right? Because it expands and it has to accommodate the whole baby. So there's a really thick wall actually of the uterus. So again, I think it's the urinary bladder, but you know, take it with a grain of salt. Cool. Any other questions? You are both learning together. Would you like me to proceed? Okay. Great. So the second lecture is about MRIs. Okay. So a few things I have to tell you about MRIs. So I looked at this lecture and it doesn't have a lot of details. Okay, but the previous groups, they had lectures which had a lot of useless details, in my opinion. And then they had some useful details. Okay, so for me, what's important in MRI when you're taking a lecture on MRI, because I'm pretty sure you haven't taken a lecture before on this, right? So you need to know somewhat briefly about the physics behind this, how an image is produced. You need to know very importantly about the different sequences. So what is the difference between T1 and T2? And then you need to know about some of the pathologies and the clinical aspects of that. Because the questions that you're going to get are most probably going to be on the sequences, which by sequences, I mean T1 or T2, or the clinical correlation. But over here in your lecture, I didn't find a lot of sequences, you know? So what I'm going to do is, let me tell you what I'm going to do. Okay, so I'll start with this lecture. And once I feel like it's missing some stuff, then I'll go to the other slides and I'll explain those, okay? I won't go into details at all, but I feel like if you're doing a radiology course, if you're spending so much time on a parallel course and you come out without knowing what a T1 and T2 is, then it's, you know, unfair to you guys. You may get a few questions on it, you may not. I'm honestly not sure what they do with the exam, but I feel that's important, okay? So again, these are different imaging modalities, and this is most probably an MRI. Hopefully, inshallah, this is an MRI. Yeah. Again, X-ray, PET scan again, Doppler, ultrasound. Okay. So what is an MRI? It is basically, it stands for magnetic resonance imaging. It's an imaging technique that uses the magnetic field and the computer-generated radio waves to create detailed images of the organs in the body, okay? So basically it uses radio waves and electromagnetic fields. So again, just reading the slides here. So what is MRI? It uses magnetic fields and radio waves to measure how much water is in different areas, tissues of the body, maps the location of water, then uses this information to generate a detailed image. Okay, so again, anything that's bold, just know it. Anything that's red, you better know it for the exam. So you better know this number of 65% of our body is water. Okay, so basically, what an MRI does is that it works on the hydrogen atoms of the body, okay? So we know that the body is 65% of water and water is made of H2O. So the most prominent element in the body is going to be hydrogen, right? And this is why we use hydrogen atoms for the MRI, right? Because we want to generate a detailed image. So that's basically what it's trying to tell you over here. And okay, the second important thing about this hydrogen. So hydrogen is present in water, right? But in different organs in the body, there's different amounts of water. And also there's hydrogen present in other tissues as well. For example, there's hydrogen present in fat, there's hydrogen present in protein. You know, all of these materials have some sort of hydrogen in them. But the bonds the hydrogen atom makes with water versus other materials is also different, right? Because a hydrogen atom is like two hydrogens combined to one oxygen molecule. Whereas, you know, in fats or proteins, you have a lot of other carbon atoms, hydrogen atoms, oxygen. So basically, the interaction a single atom feels is going to vary depending on the location of the tissue, depending on the type of material it is part of, okay? And this is important because it helps us understand how MRIs work. Okay. So this is probably the most difficult aspect of MRIs to understand, usually for people, because this is physics and people usually avoid physics. So basically you have water, right? And in water, again, there's 2 hydrogen atoms, 1 oxygen atom. And usually all of these hydrogen, we're going to call them protons for now. So hydrogen ion or hydrogen proton is the same thing. So this hydrogen atom or a proton, it's usually in any given location, it is spinning around. So it's spinning around in circles. And once it is spinning around a circle, it's spinning around a certain axis, right? And since it is spinning, it generates a tiny, tiny, tiny magnetic field. Okay, remember how in physics in high school you studied anything that's moving, any electrical current that's moving generates an electromagnetic field, or an moving electricity produces a magnetic field. It's the same idea. So this thing, it behaves like a tiny, tiny magnet. Okay, now in the human body, when there is water, these tiny magnets are going to be spinning in random locations all over the body. Okay, when they're spinning in random locations, there's no net effect of this magnetic field, right? So the fields, they're in different directions, they cancel each other out. So there is, it's how normally they're arranged. However, once we're using an MRI machine, actually, wait, just let me check how much detail they're going into. Okay. So I'm going to cover this slide and the next 4 slides with my other slides, okay? How do we get an image? Okay, till here. So let's go to the other one. Okay, so what is an MRI? So basically, it's this machine over here, and it has very, very strong magnets. And these magnets will interact with the hydrogen, and then they will help us produce an image in very, very simple terms. Okay, so let's start with this. So normally the hydrogen atoms are spinning randomly, as I just told you. So there's no net charge anywhere, okay? In an MRI, when we place them inside this very huge coil of magnets, okay, what happens is that all the hydrogens align either parallel or anti-parallel to the MRI field, okay? So BO is basically the electric current, or sorry, the magnetic field, or the magnetic, let's say current, but the magnetic field, which has been applied from the outside. And once it's very strong from the outside, what it does is that it influences all of these tiny magnets. So, magnet interacts with magnet. So these tiny magnets, they all line up. So either they line up in the direction of the magnetic field that's applied, or they align in the opposite direction. But either way, they're going to align, okay? If they align in the same direction, then we say that this is a low energy state. And if they align in an anti-parallel direction or opposite to it, we call it a high energy state, okay? So from the beginning, there was hydrogen atoms inside the human body, a lot of them. They were spinning in random locations in random directions. When we applied a magnetic current from outside, or a magnetic field from outside, this influenced the tiny magnets, and they all lined up. Either they lined up in the direction parallel to the field or against the field, okay? The ones in the field, parallel to the field, are known as low energy, and the ones opposite to it are known as high energy, okay? So when this happens, this gives us a net gradient, or a net direction of these rotations. Okay. How much detail should I explain? Okay, so basically we placed them in a machine which had a lot of which had a very strong magnetic field. Okay, now they're either arranged towards or away. Next, what we do is we send from the machine, we send a radio pulse. Okay, and this pulse basically means we send another burst, let's say, of magnetic we send a pulse of radio frequency. What is radio frequency? Okay, so radio frequency is basically an electromagnetic ray, which has so it's part of the electromagnetic spectrum. So which basically means it's like, you know, X-rays, visible rays, infrared, and then if you increase the wavelength, very high or very large wavelength and very low frequency, it's known as radio waves. These are the types of waves which are used in antennas, in old television, satellite communication, all that stuff. Okay, so what we do is we send this pulse of radio frequency. So we just send a short burst of this towards the already aligned hydrogen atoms, which are over here. And what happens is, remember how we said if they are towards it, we call it low energy. If they're away, we call it high energy. So basically, when this high energy pulse hits them, some of the ones which are in low energy, they absorb that and they change into high energy. Okay, so the majority of it becomes a high energy or changes direction. Okay, 180 degrees. Basically, this phenomena of absorbing this frequency and then changing direction is known as resonance. Okay, somebody's unmuted. Anyway, it's known as resonance. Okay, so exchange of energy between two systems at a specific frequency is known as resonance. Okay, so once you have this resonance, they're in a high energy state, and you know whenever something is in a high energy state, if you remove the pulse, or once the pulse is removed, it's going to return back to its lower energy. Okay, now once it returns back to its low energy, so basically, let's say it was this particle, it moved from here all the way here, so it changed to high energy. Once we stop giving it the extra energy, it moves back to its original position. We will detect, or once it's moving back, it's going to generate some sort of change in the electromagnetic field, which is going to be detected by the detector. And this is how we're going to get a signal, which is interpreted as an image on the machine. Does that make sense? Also, since the different organs will have different interactions of the hydrogen ions between them, between the structures, because they have, like, you know, different densities and different materials and all of that, there's going to be a specific frequency and specific signal for each and every organ. And this is how the computer is going to differentiate between organs and give us a whole spectrum of images. Now tell me, did you understand so far? You don't have to know a lot of the details, because okay, this is probably important for you. So again, so when the radio frequency is sent, the protons change their alignment from the BO. So originally, let's say they were arranged upwards, then they turned downwards. And then once this was released, they changed back upwards, right? When the radio frequency is turned off, the protons align again with the BO, which was the external magnetic field. This is known as proton relaxation. When they realign, they generate a strong magnetic field. Different tissues give off different fields, which is detected by the coil. The coil, we mean the coil outside, which was also serving as the magnet. This produces an electrical current, which is given to the computer. Wow, this is actually really clear. And the computer uses something known as a Fourier transformation to create an image. So basically, it detects all of these electrical currents, and it uses this phenomena to create an image. You just need to know the name. Okay. Cool. I'll explain again. Yeah. So again, remember how we said that a person has to be placed in an MRI machine? So the MRI machine has two components to it, or actually, let's say three components to it. Okay. The first one is this round coil. Okay. This round coil is basically made of very, very thick, strong wires. Okay. Coils. And these wires, when there's current passing through them, it generates a magnetic field, right? So what we're interested is not in the current that's passed through, we're generated in the strong magnetic field that's generated, right? So if there's a magnetic field that's generated in these coils, guess what's going to happen? There's going to be a north pole generated, there's going to be a south pole, and when the person goes inside, they're going to be between a magnetic field, okay? We call this field as the external magnetic field, or the B0. Now, once we place this person into this field, we turn the machine on, there's an electric field over here. What's happening is, until now, before we placed him inside the machine, they were, the hydrogen atoms were just spinning randomly, okay? Once we turned on the BO, once we turned on the external field, they either went in the direction of the field or away from the direction of the field, okay? Those were, and they just realigned like this, okay? Then after that, the second part of this machine is that it generates an impulse, or it just generates a frequency, radio frequency. It throws that towards the person. And once they throw it towards the person, what happens is these ones which are aligned towards the direction or parallel to the direction of the field, they gain more energy. When they gain more energy, they have enough energy to oppose the magnetic field. So they just turn the other way. You know, once you have more energy, you're more rebellious. So you switch your direction and you become anti-parallel. So then what happens is, while this pulse is going on, this energy from the pulse is absorbed by certain less energy molecules. They change into a high energy state. This high energy state is unstable, right? So as soon as the pulse is off, they have to return back to their low energy state because the extra energy they got, it's no longer there. Once they are returning back, they generate a change in the magnetic field, right? Because they're changing direction. And once they change direction, these tiny, tiny, tiny currents are generated, which are detected by the computer using Fourier transformation. Okay, I did not get the magnetic BO part. So is it clear now? All the radio pulse, is it to make more? Yes, exactly. It's to make more hydrogen atoms anti-parallel, to be in a high energy state. Exactly, because what we're interested in is them going back to the low energy state. So the magnetic field is the arrow in the middle of the atom. No, the magnetic field is not the arrow in the middle of the atom. The arrow in the middle of the atom is the direction of its alignment. So it's the magnetic field of this atom itself. But the magnetic field, the actual magnetic field is something like this. It is something like this. It's actually like going like this and going like this, which we can't really see over here. It's going like this and going like this and going like this. Okay, so it's external. It's from the outside and it's just hitting the body. Okay. So the energy they give off when they realign is what is detected by the computer. Yes, exactly. Because, you know, once they're going back, or once they are over here, the term proton relaxation is mentioned. So once they're relaxing, they will relax at different speeds depending on the surrounding interactions with the object. For example, if it's fluid, it may relax faster. If it is, well, actually it relaxes slower. Anyway, if it's fluid, it may relax at a different speed as compared to when it is a solid or when it is a gas. Okay. So, or if it's a fluid of different densities, they may relax at different speeds. You know, so once there's a difference between the relaxation, that's how the computer checks, okay, this is one substance, this is just fluid, and this is a different type of fluid, this is solid, this is heavier solid, this is bone, this is muscle, you know, all of that stuff. So yeah, that's about it. So was this physics part clear? If there's any questions, I don't mind repeating at all, because this is probably the most difficult thing to understand. Okay. Okay. Next we have planes of the body, nor your location. Okay, so let's go to the other, your original lecture. Okay, so how do we get an image? The coil acts as an antenna and detects the released energy as electrical current. Okay, so that makes sense. We mentioned this. Okay. Electrical current is transformed via a computer using a mathematical calculation known as the Fourier transformation. Mathematical calculation that is used to change the electrical current into an image. Okay, so it's basically complex maths that we run away from. Because protons are in different types of tissues, they give off different amounts of energy, and the result of the transformed energy is a detailed image of the tissue. Okay, that makes sense hopefully now. Now this, I don't know why he included this, but I think it's just for general information. So basically the Earth has a magnetic field as well. It's a bit different from the geographic field, but sure, let's call it the geomagnetic field. And the field is from the inside to the outside. Okay. Is generated by electrical currents due to the motion of convection currents in the mixture of molten iron and nickel in the Earth's outer core. So basically, the Earth is very, very hot from the inside, and there's lava inside, and lava has molten metals inside it, and these metals, they're flowing, right? So once they're flowing in a particular direction or something, whenever metal or current is flowing, it generates a magnetic field. So basically the whole Earth generates as a magnet. That's what they're trying to say. Yeah, just note the red things. Again, I don't know how they're going to ask you this, but they may. This is probably important to memorize. So the magnitude of the Earth's field is this much. This is micro Tesla. Okay, Tesla is the unit for electrical field, magnetic field, sorry. It's the unit for magnetic field. And micro means that it is 100,000 portion of it. Okay, so most scanners that we use in hospitals and clinics are 1.5 to 3 Teslas. So to put it into perspective, a 3 Tesla MRI scanner is 60,000 times stronger than the Earth's magnetic field. So, this is why when you're walking around, you don't feel that strong magnetic field, or you're not pulled towards one place. So basically what they're trying to tell you over here is that this is very, very, very strong. Okay. Cool. So MRI safety. Then he talks about some materials are MRI safe, some are MRI conditional, and some are unsafe. So you always need to make sure that the patient who is going into the scan does not have any magnetic material or any metal that can be magnetized. Okay, so it's completely non-magnetic, non-electrically conductive, because flowing electricity can also influence magnetic fields, and non-RF reactive, so non-radio frequency reactive, because remember how we said the hydrogen atom respond to these radio frequency. If something else starts responding, then we have a problem, right? So usually this is probably safe, this is conditional, and this is no. So how is this important? So for example, a person has a pacemaker in their body. A pacemaker is like this machine which sends electrical currents to the heart to make sure it's beating properly. So there's electricity over there, right? And it's made of a metal. So in case you have this very strong magnet, it can literally rip out of the human body because they're very, very strong, right? So we always have to ask and make sure the patient has something like this. Some people get, if they have a fracture of their leg, they get a rod placed inside, so they use titanium or some other material which will not be influenced by MRI machines or stuff like this, so it's very, very important. Also, another very, very important thing that's usually underlooked is jewelry. So whenever a person is going, you ask them to take off all metal, all jewelry, all belts, and especially if a person has tattoo. Some tattoos can have inks which have a magnetic component to them. If a person goes into a scan, their entire skin from that portion is ripping off. So you have to ask that. You have to ask if there's any tattoos on the body, even if you think it's not appropriate to ask, you have to ask, okay? So MRI safety risk, because MRI uses powerful magnets, the presence of metal in your body can be a safety hazard. Okay, cool. Yeah, you'll complete a questionnaire asking about this. Okay. So as I said, metallic joint prosthesis, artificial heart valves, implantable heart defibrillation. This is basically something similar to a pacemaker. Drug infusion pumps, nerve stimulators, basically any foreign material that may have metal can be influenced. Stents, clips, screws, surgical tapes, all this. Cochlear implant. Cochlear implant is basically a type of device that is placed inside the skull to allow some patients to hear better. Intrauterine device, this is used as a contraceptive. Some women like to place it, it's placed inside the uterus, and it can either be made up of plastic, I believe, or copper. The ones which are made up of copper or like metal, you need to make sure that it is MRI safe. Any bullet wound, shrapnel. Shrapnel is basically a fragment of the bullet that just goes into the person. Again, any bullet wound is also important because it's a foreign material and can really damage the person. Permanent makeup, apparently, I do not know this. Cool. Yeah, we always ask female patients if they are or could be pregnant. Why? Because technically we haven't carried out studies, technically it's not ionizing radiation, right? It's on the lower spectrum. The RF frequency is on the lower spectrum. We don't really know what effect it has, but since it's such a strong, magnetic field, something can happen, 60,000 times from normal, it's probably something is happening, but we haven't really documented it. So let's be on the safe side with children, if the small child is breastfeeding. Okay, so over here, breastfeeding, it doesn't really have to do anything with the MRI, but more with the contrast material. So sometimes the way we give contrast material for MRIs, we give gadolinium, and I'm pretty sure Maklad talked about this. But gadolinium, it can somehow, since we give it in the blood, it may change the composition of breast milk, which may be harmful to the baby. We're not sure of it, so safety is always better. You can also ask patients if kidney or liver problems. So why do we ask about this? Because if in case they're getting a contrast, the contrast is excreted through the kidneys. So if a person has a problem with the kidney, then you would probably not give them contrast, or you would give them contrast which is not broken up by the kidney, it's broken up by the liver. And again, liver can also break up some contrasts, excrete, metabolize contrast. By excrete and metabolize, I mean change it into excretory products, right? So in case the liver is not working properly and you give some sort of contrast material which uses the liver to be metabolized, then the contrast is just going to stay in the body for a long time and may damage a lot of other structures. Somebody mentioned something. Yes, exactly. It's gadolinium. Very nice. MRI safety, cool. Okay, contraindications. So contraindications include most cochlear implants. So see, cochlear implants, what we see is this part, right? This part outside, which is all cool, but there's a metallic part inside as well, which we're not showing in this image. Cardiac pacemakers. So this is a pacemaker, and it has wires, it has electrical current flowing through, so you don't give it shrapnel. Oh, this is a shrapnel right here. Right, so this is not an MRI, just so you know. This is probably a CT, because you can see the shrapnel as a very bright object, and that metal appears to be white in the CT. So there you go, that's shrapnel. Metallic foreign bodies in the eyes. Okay, cool. This is a weird picture, but okay. Okay, see, did you remove all of your piercings? It's not as pretty as this. Literally the whole skin just rips out. You can see how strong this is, you can see how strong this is, and now you would believe when we say it's a very, very, very strong magnet. Okay, contraindications. So again, the safety in the first trimester is uncertain, because in the first trimester, that's when all the organs are growing and developing and forming, Since MRI does not use any ionizing radiation, it's generally favored. So if there was a choice between CT and MRI, you would always go for MRI in a pregnant patient. But if there was a choice between MRI and no MRI, or MRI or ultrasound, you'd always give preference to no MRI or ultrasound. And okay, generally MRI is more expensive, time consuming. Okay, so MRI machines are very, very expensive. Okay, they need a huge room to maintain. They always need to have the material, all the room at a certain temperature. It takes up the entire room. If somebody has had an MRI scan before, they would know it takes literally like half an hour, even more. You're just confined to that one small room for the entire time. If you're claustrophobic or you're afraid of closed spaces, it's very, very troublesome. They ask you not to move, because if you move, the image is going to, there's going to be artifacts in the image and stuff. So it's very difficult to put a child in there and ask him not to move, unless he's like sleeping or something. It's very difficult to ask someone who's afraid of closed spaces to do this. And it's also very, very expensive. So I think entire KFSH maybe has 2 MRI machines, or maybe 3. Like, I don't think they have more than that. It's very expensive. One MRI scan costs around 5,000 reals. So, it's not something that you would go for as the first step in any situation, but it gives you the best image details. So that's why it's usually done as the final step. When you can't figure anything out, then this is when you go for it. See, they're trying to make a joke. Nice joke. Okay. Yeah, you see the patient went hungry. Yeah, see, microwaves have a bit shorter frequency, so sure, have a bit higher frequency than radio waves. MRI history, just note the dates. I'm sorry you have to memorize this. I apologize in advance. Just know the dates. This is the first time it happened. It was with an alive mouse. Cool. And then he got a Nobel Prize. Great, amazing. In the past, they were not as detailed. Cool, very nice. So as you can see, this was very weird, very difficult to interpret as well. And as time passed by, they became cheaper and they became easier to do and more widespread. Hydatid cyst is basically a cyst in the liver, which can happen due to some parasites or some pathogens. Material in the CBD. CBD stands for common bile duct. Basically, it's telling you that there's some problem whether you don't know this. Okay. So now we're done with the first part. Do you have any questions so far? Yes, exactly. This is what I was going to do. So let's take a prayer break for 10 minutes, please, because I need to pray and I'm sure you guys need to pray. Let's take a quick 10-minute break because we're done with the first part. If you guys have any questions, you can ask right now. Otherwise, we'll take a break and we will return on at 7:10. Okay. Great, perfect. So I shall see you guys in 10 minutes, inshallah. There's not a lot, but there is some very, very important stuff later on. So please come back. And yeah. GND, you guys can stop dilated. Nice. Okay. So for the recording again, now we're going to move on to the clinical applications of an MRI. And basically, since you guys haven't taken any of these conditions, it's best to just memorize or have a very good idea of which modality is used where. So for MRI, the most important organ is probably the brain. And a few others, but we'll talk about that. So what does aneurysm mean? Aneurysm basically means an abnormal dilatation of a blood vessel, right? And we can see that in an MRI. Basically, we can see the brain in a very detailed manner with an MRI, okay? Disorders of the eye and inner ear. So we can also use ultrasound for the eye, but inner ear, there's no way we can use an ultrasound. Multiple sclerosis. So what happens in MS is that you have tiny lesions in the white matter. Okay, you guys took neuro second year. Okay, so you guys know what gray matter and white matter is, right? So white matter in the brain is this part, and gray matter is the surrounding part, right? So gray matter is going to be present on the outside since this is the brain. White matter is going to be present inside. So if you have many white lesions here, here, here in the white matter, it's probably multiple sclerosis, okay? Spinal cord diseases, so it's also used for the spinal cord. So disease of the spinal cord can be done using an MRI. On children, remember, you can do an ultrasound of the spine to see spinal cord disorders. Congenital disorders is the spinal bifida, okay? Stroke. So whenever you have a problem of a stroke, 99% of the time you are going to do a non-contrast CT. Why? Because you want to rule out if it's hemorrhagic or not. I'm sure Maklad covered this. There's no way he did not cover this, okay? So you can also, if a question asks you, what is the initial modality you will use in case of a stroke? You know, they bring a patient who can't suddenly walk or he has numbness or whatever. They mention the word ischemia, you know it's a stroke, right? Facial paralysis, whatever. When they ask you the imaging modality, you will say non-contrast head CT. But if they ask you which is the best imaging modality or most accurate or can detect stroke earliest, you can mention MRI. because an MRI can technically measure, detect stroke within 30 minutes of onset, okay? Whereas an MRI, a CT takes like 6 hours or so. However, an MRI is so expensive and so rare and takes half an hour just to perform the procedure. So there's actually technically no clinical value of doing an MRI for a stroke, okay? But just so you know, the most detailed and the most accurate is going to be, or the earliest detection is going to be by an MRI, okay? Then you have tumors. So any tumors in the brain, since you can see a lot of detail over in the brain, it's usually MRI. This is probably a tumor. This is probably a tumor as well. And then brain injury from trauma, okay, that again, you can use an MRI. Also, there's a condition known as cavernous malformations or cavernous sinus malformations, right? Basically, you can also, that's also a problem in the brain, and you can also see that using a brain MRI. Okay, so how do I know this is a tumor? Right, so we have questions. No, you can't. The reason for that is you can't use a CT because you can't get that detailed of information about the brain, because a CT, you studied windows and stuff, right? So the material is, it's very difficult to differentiate with a CT because they're almost the same density. But with an MRI, since it's different materials and it's based on the hydrogen atoms interactions in the different structures, you can get a very, very clear image. You can even differentiate between, you know, gray matter, white matter, you know, that this is clearly, you know, bright over here, right? You can tell it's irregular over here, you know, that there is, this is probably a mass. That's why I'm saying it's a mass, because it's irregular. There's areas of dark and light, so we know it's not just fluid or not just solid, you know. So you can get a lot of details. This is most probably a stroke. And when we go into sequences, then I'll go into more details of why I'm saying this is probably a stroke, okay? Okay, so that was just normal MRI. Then there's something known as an fMRI or a functional MRI, okay? And basically what that does is that it produces images, and it can actually detect blood flow to certain regions of the brain, okay? Why is that useful? It's useful for, let's say when you are doing is, okay, so how does it work, first of all? So the way this thing works is that, let's say during surgery, I'm a neurosurgeon, I'm doing surgery, and I want to know which part of the brain is very important for doing a certain function, right? So in neuro, you took that, this is probably the cortex, and this is probably the temporal lobe. So let's say we ask the patient to think of something or say something, the temporal lobe is going to light up because that is the Wernicke's area, right? So when they have speech, you know, they're talking or they're listening or something, certain action which would light up this area of the brain or use this area of the brain. If we're using a functional MRI, if this part of the brain is being used, we would be able to detect it. Why? Because this part of the brain would have more oxygen going towards that, because there's going to be more blood flow towards that area. And this type of MRI can detect the amount of oxyhemoglobin to an area compared to other areas, okay? So basically, it's used for determining the important location during surgery, assess damage from a head injury. So let's say a patient got a head injury, and now he can't move one area of his arm, you know? So we want to see if it's a problem with the brain or not. So we put him in a functional MRI, and then we ask him, okay, now move your hand. Or if you can't move his hand, try to move your hand. If we know those areas are firing in the brain, then we'll know, okay, this part is functional, there's a problem elsewhere, you know? Disorders such as Alzheimer's, again, Alzheimer's is a problem in memory of a person, and you may also use an fMRI. This fMRI, it's not used in clinical practice usually. It's very, very rare to use it. I think it's only used in surgeries maybe. Otherwise, it's mainly used for research, right? Okay, so then there's another sequence. Remember how I said sequences? So sequences basically means different images that are produced by an MRI. So you have something known as T1, T2 flare. You can have fat suppression, you can have diffusion weighted. I'm only going to talk about 4 of them towards the end, okay? Over here, this is a flare image, flare MRI, demonstrating a left frontal lobe-lid glioma. So glioma is basically a tumor, frontal because it's in the frontal lobe, and lobe-lid because it's not that bad. Performed at 3 Tesla, and the patient was tapping his finger of the right hand. So when he was tapping his finger, this part of the brain was lighting up. So they knew that this part of the brain is not involved, or the tumor is not extending to this important part of the brain. So they can just excise it from here, okay? That's the general idea. Okay, so MRI of the heart and great vessels. So this is the heart, if you can imagine. This is the ventricles. These are the 2 atria, and this is basically a corona. No, not a corona. This is a transverse section. Okay. This is the apex. This is the base of the heart. These are some vessels. So MRI, it gives us the size and function of the heart's chambers. So it does something similar to an echo. Thickness of movements of the walls can be observed. Okay. Extent of heart attacks or disease can be observed. So basically what they're trying to say is that blood vessels and the heart the MRI can also be used for these. However, usually in clinical practice, what do we use for the heart? For all of these functions, we use the echo. If in case the echo is not clear, or they want to plan for their surgery and they want very detailed measurements, then they may do an MRI, okay? But it's usually not done. This patient is giving contrast. You see that the blood vessel has lighted up. You see how all of these are lit up. It probably had contrast gadolinium, okay? Then MRI can also be used for the abdomen. So you can see very, very clearly, this is the liver, probably. Yeah, liver. This is a kidney, probably the spleen. This is the right side, this is the left side, just for your information. So yeah, liver can be seen over here. Bile ducts, probably, I don't know where they are over here. Probably this thing, I'm not sure. Spleen over here. Pancreas is this organ over here, which you can't really see. Uterus, ovaries, prostate. Okay, so basically soft tissue, right? So what we know about MRI so far, it's used for the brain, which is a soft tissue. It's used for the abdomen, which is a soft tissue, and it's used for the heart, which is a soft tissue, right? Prostate and ovaries. So you guys know what the prostate is. Basically, it is an organ which sits right above the bladder. So this is the bladder over here. This is the prostate over here. In front of the bladder, not above, sorry. So this is, again, a transverse cut. And if you can see, these are the two muscles of the pelvic region. This is the urethra outside. And over here, this is the prostate, and behind it is the bladder, which is full of fluid. Now over here, they're showing you that there's this large mass that's even, you know, going outside the boundaries or something. I don't know exactly what this is. Looks like some sort of cancer to me, but I'm not sure. Okay, so they're just trying to tell you that you can see the ovaries, prostate, and the uterus with this. Okay, so probably the most important organs for you guys is MRI of the brain and MRI of the MSK. So the soft tissues and bones sometimes. It's not really for the bones, you know, it's for the ligaments and the tendons and stuff. So joint abnormalities caused by traumatic or repetitive injuries, such as torn cartilage or ligaments, that's what we said. These are abnormalities. So again, it can look at the spine, and if we know that, if we see there's a problem with the spine, we can also see the areas nearby, which are the discs of the vertebra. If they are dislocated, it may impinge on the spine, and we can see that on an MRI. Bone infections. So sometimes, if you can't see enough details with an X-ray or a CT, you can do an MRI, but I don't think this is very common for bone infections. Tumors of the bones and soft tissues. So again, you know, soft tissues, and to know if it's extending to the soft tissues, the tumor is extending to the soft tissue, we may use an MRI. So over here, this is most probably the ACL. Because the ACL attaches anteriorly. Okay, so you see this dark band over here? This dark band is the ACL, okay, not this white stuff. So if this dark band is intact, that means the ACL is fine. if there's a tear over here, you can see this white stuff. You can see a lot of this white stuff, and that basically shows you that there's some inflammation around it. Okay, so this is probably a tear, but I'm not exactly sure. Okay, so probably normal, probably a tear. Not exactly sure. Okay, so over here, what they say is MRI bones and joints of breast. So the reason why they said something so weird is because breast cancer, the first thing that one of the first organs it spreads to is the bones. So if you suspect a person has breast cancer, you can do an MRI of the breast and you would see these spiraculated lesions that looks like breast cancer. But if you're suspecting breast cancer, you can also get metastasis to the bones. So over here if a patient complains of difficulty, a patient with known breast cancer complains with difficulty or knee pain. You look at the X-ray, you don't really see much, but once you look at the MRI, you see, oh wow, there was a whole metastasis over here. Okay, so it could be used for cancer as well. Now it says not so old practice. So basically, once upon a time in the 80s, whenever you had an MSK injury, what they would do is they would either do an X-ray, and if that was fine, they would say, you know, just walk it off or give it rest or whatever. But if a person was sure that they had a problem in either their menisci, these are menisci, or in the ligaments, then they would just open up the whole knee just to find that out, right? But now that we have MRIs, that process is a lot better. Somebody has a question. Can't we use the bone scan? Yes, we can do a bone scan as well, but we can use an MRI as well. But you're right, we would probably do a bone scan if we were staging it, or yeah, you're right. So prehistory, I don't exactly know what they're trying to say here. Yeah, so what they're saying is usually if you have, let's say, knee pain, usually they would give you an RX, which is a prescription. So they would give you painkillers, right? And then if you still say you have pain and they're suspecting a soft tissue injury, or they're suspecting a cyst or a swelling or something, they may do an ultrasound. Because you can see soft tissues around, right? They may do a popliteal ultrasound and see a Baker's cyst or something, which is basically swelling behind the knee. And they may do a CT scan because they're suspecting a bony problem. They may do just an X-ray. And then lastly, they would do an MRI when they're like, okay, you know what, we ruled out all the other bony causes and stuff, and there's still a problem, you may do an MRI. In the previous times, they just used to say, okay, nothing, you just go home, don't complain, just walk it off, I guess. So over here, what they have shown, they're showing you over here, you see how this is like a bow tie, there's two triangles over here. So these are the menisci. So what is meniscus? Basically, they're C-shaped rings, and they basically act as shock absorbers in the knee, and they help prevent friction between the two bones, right? So when we see these two triangles, we call it a bow tie sign. And if there's, sometimes they can have a tear inside them. So a tear can be seen very, very visibly between them. So you can see a tear here, you can see a tear over here, and see a tear over here, right? So basically what they're trying to show you, okay, so this is an ACL tear for sure, because you see how distorted this is. This isn't like a good black line. It's filled with white stuff and different colors. It's basically showing you that there's a tear over here, and then it's also showing you that there's a lot of inflammation because there's inflammation around the tear. Okay, so now value and usefulness of MRI. So this is a 69-year-old patient who had pain and swelling in the inner left thigh, which lasts for 3 weeks. My explanation, it was hard palpation, hard to palpate without erythema and no previous trauma, okay? So again, this is an MSK problem. So immediately what would be your initial thing to do? You'd probably order an X-ray, right? If the patient was complaining, or if you're suspecting a fracture. However, this is a bit old, right? It lasts for 3 weeks. So we know it's not that immediate, but there's still pain and swelling. So they could do an ultrasound, but a more detailed image would be produced by an MRI. So what they do is they actually did an MRI, and this is basically a cross-section of the leg, and they saw this huge lesion, right? This huge lesion. So this was some sort of mass that was present in this person, and the anatomic value of this was that once they saw this region, they also saw that there is a neurovascular bundle nearby, and this mass was probably compressing on this bundle of nerves, and this nerve was basically causing the pain because it was being stretched or compressed. Okay, so they do some sort of management to remove the mass, or find either biopsy to see what it has or anything. Again, ultrasound can be used for biopsy. So I think this is the same case they're talking about. So they do an ultrasound guided biopsy, I guess. So this over here, this is the needle that's being guided for the biopsy, I'm guessing. So that's basically the case that they had described, So after this, they did an ultrasound to check what this was made of, and if this was an abscess or a cyst or mass, whatever, or what type of mass this was. Anyways, we have the other case. 56-year-old gentleman, ankle pain for the past 1.5 months with inflammatory signs. So there's redness, there's swelling, rubor, all of those stuff, pallor, rubor. And he was treated with NSAIDs. So NSAIDs are supposed to decrease the inflammation, and there was only a mild improvement. So he comes again after 1.5 months, and he's like, what, I still have pain. So what do I have? So they do they do an X-ray. It doesn't show much, can't see much. Then they do a high resolution MRI, and what they see is that there is an increased space in the cartilage. So the cartilage, it's an irregularity over here. And basically they find out that it's a hairline fracture or something, or there's some problem that's causing this to happen. You see this? There's some problem that's causing this to happen, so they have surgery and they remove the problem. I'm not sure exactly what the problem is. It's probably a fracture because the cartilage may be leaking, so there's probably a hairline fracture or something that's hurting him really bad. But basically, MRIs are used for the MSK system. That's what they're trying to say. So the most important thing that we learned about MRIs regarding the clinical aspect is that it's used for the brain, and it's used for the MSK and the spinal cord. Yeah, basically. So now I want to talk about the sequences because I feel that they're very, very important. And you may be asked about them in the exam, okay? So do you guys have any questions before I move on to the sequences? Do you want me to explain the sequences? I know you guys are really tired, but I feel it's very, very important. So I apologize, but I'm still gonna explain it. Okay, so basically, when we are looking at an MRI, again, it's the same thing as CTs. You need to be very careful about three things. So the first thing that you need to know about is the plane. So you want, when you're looking at the image, you want to see which plane this is. Is it a transverse plane? Is it a coronal section? Is it a sagittal section? Whatever. And then the second thing is that you need to know your location. So you need to know which part of the brain you're at, okay? So for example, I'm over here. This is the top of the brain, then I'm going down, then I can see the eyes over here, then I'm going down, I can see the nose, and then I'm at the lower jaw, okay? So these two things are very, very important whenever you're looking at an image, and usually with an MRI and the CT, you can scroll up and down so you know exactly where you are, right? So we use these landmarks outside to get a sense of it, and then we look at the pathology, because we want to know how far away it's going, how bad is it, and stuff like this. Okay, the third thing that you need to know is which sequence this is. And why is this important? It's important because each sequence has a different appearance, okay? So for example, in T1, something appears to be darker, whereas in T2, it appears to be lighter. So you don't want to be confused and think this is an abnormality when in reality it was just normal, okay? And the second really important thing is that different sequences have different advantages and disadvantages and uses. So this is why I feel that sequences are really important. And if you just understand sequences and nothing else from this lecture, I think it's still enough. Okay, so T1 weighted sequences. So the reason why we call it T1 and T2 is related to different settings that they set on the MRI machine, okay? So remember how we said there is a proton relaxation once they are, once they're going back to their normal position. So T1 takes readings at a different time, and T2 takes readings at a different time, okay? That's basically the most simplified version of this. And based on those different readings, you get different colors of the substances, okay? So over here, this is T1. So T1 is usually used for, it usually represents normal anatomy, okay? By normal anatomy, I mean that the gray matter will appear to be darker and the white matter will appear to be lighter, you know, gray, darker, white, lighter. So over here, this is a T1 image. So we can see that the gray matter is darker and the white matter inside is lighter, okay? So fluid always appears to be black in the T1 image. So this is a T1 image and the fluid appears to be black. So where is the fluid exactly? So there's fluid over here inside the ventricles. And more importantly, there is fluid over here, because remember, this is the one of the sinuses, the venous part that drains the blood from the brain. So this is one of the sinuses. I think this is the sagittal sinus, if I'm not wrong, because it's going from here all the way back, right? So you always want to look at this place and this place to see which sequence this is. So fat appears to be white over here. This is why white matter appears to be whiter, because it has more fat, because it's surrounded by the myelin sheath. And muscle appears to be gray in between, okay? So this usually reflects the normal anatomy. Okay, now, if they say this is a T1 image or not, how do you check? You always, if it's the brain, you always look at this portion and look at the white matter and look at the gray matter, okay? Don't rely on the ventricles, okay? And why do we not rely on the ventricles? Because if they do give contrast, I'm not exactly sure about the ventricles, but this part will definitely light up because it's going to be veins, right? There's the blood-brain barrier, so I'm not exactly sure of the contrast over here, but this will definitely light up. And if this lights up, you know that there is a contrast. Okay. So gray matter is darker than white matter. Okay, great. So T2 weighted images are usually used for pathology, and it's the reverse. So white matter appears to be darker and gray matter appears to be lighter. So white matter is darker than gray matter, okay? This is what's usually used in the scenario. If they don't give you anything and they just give you an image, usually it's going to be a T2, but for the sake of your exam, just compare these two and see what sequence this is, okay? So now this is a very good table for you guys. So it tells you that in T1, fat is going to be bright, water is going to be dark. And yeah, this is for the T2. Now over here, if you see in T2, the CSF lights up, right? So that's why you know that this is T2. So again, if the CSF is black, you know that this is probably T1. The CSF is white, it could be T1, or it could be T1 with contrast, or it could be T2, because CSF is white in T2, okay? This is the most important thing over here. And again, T1 provides the most anatomically relevant images. CSF, fluid in CSF is dark, and then fluid is bright in T2. What is your question? Yes, T2 is the exact opposite of T1 in terms of colors of the images. Yes, you're right. Okay, now the only reason I brought this slide is because this was asked previously in one of the lectures. So I thought that this is still important because you may get a question on this. So basically the only thing you need to remember over here is that T1 weighted image has a short TR and a short TE, whereas T2 has long TR and long TE. You don't need to know what TR and TE is. Just memorize it, okay? TE is the time for echo, time it takes for the echoes to return, and TR is the time it takes for the protons to relax, okay? So remember how I said they measure TE and TR at different, they take readings at different stages. That's what I meant. So when they take it at a shorter TR and shorter TE, they would get T1. When they take it at a longer TR and longer TE, they would get T2, okay? Does that make sense? So like, for example, the protons are relaxing. So if I take the image earlier, it's probably T1. If I take the image later, that's probably T2, okay? That's the easiest way to know this. Also, just please know this, that yeah, so in both cases, fluid takes a longer time and fat is detected earlier. Okay. Fluid takes a longer time and fat is detected earlier. Okay, just know this information as well. Okay, next we have two other sequences. They're probably not that important, but it's good for you to know. So what is FLAIR? It was mentioned earlier, right? So FLAIR is fluid attenuation inversion recovery. Forget about that. What is it? It is similar to T2, but the fluid appears to be dark. Okay, so let's go over here. So again, T1. How do we know if this is T1 or T2? We look at the white matter and the gray matter. If the white matter appears to be bright and the gray matter is dark, we know this is normal anatomy, we know this is T1, okay? Then if we see this, we see that the ventricles are lighted up and we see that the white matter appears to be darker. We know that this is T2. Over here, the difference between this and this is only the CSF. The CSF is bright over here, but dark over here. The anatomy is still the same as T2. So white matter appears to be darker and gray matter appears to be lighter over here, okay? So when is FLAIR used? Sometimes FLAIR is used when we want to cancel out the CSF because, sometimes there may be a tumor or something which is causing, which absorbs the contrast as well. Or let's say there's no contrast, but there is a tumor which has some liquid in it and all liquids appear to be bright on T2. So what it's going to do is it's going to suppress the normal liquids, okay? So when normal liquids are suppressed, only the thing that will remain lighted up is the abnormal liquid. And that's why FLAIR is useful, okay? So it's basically used to suppress CSF. I can go into a bit more detail because you guys have taken neuro, okay? Now, again, remember how I said if there is a contrast, you can still be confused. So over here, this is the dark matter, gray matter. This is the gray matter, and you can't really tell if it has contrast or not. So basically, the white matter over here is inside, it appears to be whiter. The gray matter is outside, it appears to be darker. So we know that this is T1. And the CFS is black, okay, we know this is T1. Over here, again, the white matter appears to be brighter, or it's quote unquote supposed to appear brighter, okay? And the gray matter will appear darker. So how do you know that there is contrast? Because there is going to be contrast in the blood vessels, okay? So in an image like this, how do I know if there's contrast? Because this part is going to be white. The rest of it may be all black, but this part is going to be white, and this part here is going to be white. So I know, okay, so this is probably T1 with contrast, okay? Okay, so again, we have FLAIR. How do we know it's FLAIR? Again, we look at the gray matter, sorry, we look at the white matter and we know that this is dark and the gray matter is light. So we know that this is some type of T2 thing, but there's no CSF white, it's dark over here. So this is probably CSF suppression or FLAIR, okay? And then we have diffusion weighted. So again, remember how I said if you have a stroke, you can detect a stroke within 30 minutes. The reason why you can detect a stroke under 30 minutes with an MRI is when you use something known as diffusion weighted sequence. And the only thing I want you to know from diffusion weighted is that it is used for acute strokes. And if there is an acute stroke, it will light up the affected region. Now, for your information, how does diffusion weighted work? The way it works is that fluid which is free flowing, which is flowing normally, such as CSF, such as blood, it will not be detected. But fluid which is stagnant, for example, when there's a stroke, there's going to be ischemia, and then there's going to be inflammation, and this inflammation will have fluid which is stagnant, it's not really flowing away. We'll know that this will light up, and we will know that this is a stroke. Okay, so acute stroke is diffusion weighted. That's all I want you to know. Yes, so FLAIR is T2, but the CFS is dark. Exactly. Okay, so now this is a quick summary for you again. So high means bright, low means dark. So in T1, you're going to have fat, which is bright, and you're going to have CSF, which is dark. In T2, we usually use it for pathology because it's going to appear to be brighter. Okay, this is just for your information. This is the most important thing, which is dark and what is not dark. Okay, white matter and gray matter. Cool. Okay. So now we are done with these sequences as well. Do you have any questions in the sequences till now? So we talked about 5 sequences. We talked about T1. We talked about T1 with contrast. We talked about T2. We talked about flare, and we talked about diffusion weighted. Do you have any problems with these? Differentiating between these? Okay, great. Lastly, this I think is very important for you guys because you haven't taken a lot of pathology. So over here, this is from Ambas, by the way, and there's also some notes I think I made. I did this last year, but I think it's very, very useful for you guys. So basically, the questions that you're going to receive in the exam are going to be clinical scenarios, and you're going to get proper lectures on clinical scenarios. So I just feel like it's important for me to explain this. So let's say a person comes to you complaining of right upper quadrant pain. So this is most probably going to be, what's the condition? You guys can write in the chat, you guys can unmute yourself, whatever you want. So right upper quadrant pain is usually going to be cholecystitis, exactly. So for cholecystitis, the first imaging modality that you're going to use is going to be an ultrasound of the abdomen, okay? And on the ultrasound, you'll see all of the things, you know, the edema around it, the sludge, the stone, whatever, okay? If you have right lower quadrant pain, it is most probably appendicitis. Yes, very nice, okay? If it's on the left side, it could be appendicitis, or it could be ectopic pregnancy as well. If it's on the right side, it could be ectopic pregnancy as well. The reason why I'm saying that so much is I remember we got a question on ectopic pregnancy and we had no clue what it was, okay? So that's why I think it's best to explain it to you guys. So again, what are the symptoms they're going to present with? They're going to have pain, they're going to have nausea, they're going to have vomiting, they can't eat, whatever, extreme pain. Ectopic pregnancy or appendicitis, either way. What are you going to do for this? If you're suspecting acute appendicitis, the best test for acute appendicitis is CT abdomen and pelvis with IV contrast, okay? That is the best test for acute appendicitis, okay? If the scenario is ectopic pregnancy, they'll make it very clear for you guys. It'll be a female of childbearing age. She would come with the same symptoms, nausea, vomiting, pain, abdominal pain, but they may mention she could be pregnant. They may mention she hasn't had her periods for a while. They'll mention something to make it very obvious for you, okay? But since we didn't know what it meant, we were just confused, okay? Again, in that case, what would you do? Probably the same thing, because you want to rule out acute appendicitis, you can do an abdominal ultrasound. Yeah, for ectopic pregnancy, I would go with abdominal ultrasound. Oh yeah, and also there's a difference between right or lower quadrant pain and pelvic pain. Pelvic pain is most probably the ectopic pregnancy, okay? So you would go for ultrasound pelvis. They may mention HCG is positive if it's an ectopic pregnancy, so that's also one more clue in the question. But see, if you are more towards ectopic pregnancy, you're going to choose ultrasound of the pelvis. If you're more towards acute appendicitis, you would still go with CT abdomen with pelvis with IV contrast, okay? You get the difference of how this can present. If it's non-localized pain, then again, you would go with CT abdomen and pelvis with IV contrast because that's most probably still appendicitis, okay? Suprapubic pain, you would go with ultrasound. Why? Because suprapubic and pelvic is a bit more similar, and suprapubic can also mean the bladder, so you would go with the ultrasound, okay? Okay, so these are conditions that you have taken over this course. So acute appendicitis, CT abdomen with pelvis with IV contrast. With contrast is very important. If you have a renal stone, you would do CT abdomen without contrast. If this is not available, then you can do an ultrasound, okay? But nephrolithiasis or kidney stone, your first modality is going to be CT abdomen without contrast, because you can see the stone without contrast, right? So you don't really need contrast. And acute appendicitis, you can either go ultrasound abdomen, but usually what they go for is CT abdomen, okay? Check notes, so just let me check because I don't remember what I wrote here last year. Oh, wow. Okay, so these modalities may change depending on the specific details in the scenario. So cholecystitis, stone, and ectopic pregnancy. Oh, I mentioned all of this. Nice. Okay, again, if it's children or pregnant women, just remember you can't use CT. So that's another clue, like, you know, these things you want to know. You may use CT with IV contrast. You may use ultrasound. And you may see the target sign on the ultrasound. Nice, I wrote this. In the CT, you may see that's distended or swollen and large. There's edema around the appendix, appears to be murky. You can't really see it properly. Ovarian torsion, okay. So the reason I brought this is because it's one of those mimickers of acute appendicitis. Again, so there's a blood vessel and then there's the ovary, and the ovary can twist on itself and block the vein, so the blood cannot flow out. Okay, so in case we're suspecting this, they'll most probably mention patient came in with extreme pain and pelvic pain, and it's a female, obviously. You know, so she may have nausea, vomiting. Again, you know, you may do an pelvic ultrasound with the Doppler, because why with the Doppler? Remember how we said that we want to see blood flow, and with the Doppler it'll show us that there is decreased blood flow. So that's basically it. Lastly, this over here is an example of a diffusion weighted imaging. So you see this thing over here, this bright thing, it's probably a focal problem, I think. What do I say in the note? Okay, so what it says over here is that this picture is diffusion weighted imaging, and we said that the stroke appears white, so this bright thing appears to be a stroke. And this is a flare, okay? Forget about the middle one. That's something else, another sequence that I don't want you to know about. But this over here is a flare. So why is it a flare? Again, you can see that the white matter appears to be dark. The gray matter appears to be light, so it's opposite of normal. So this is T2 sequence. And then we see that the CSF is dark, so we know that this is a flare, not T2. Cool. So we're done. Thank you so much for attending. I think I covered everything. Just let me go back and check we're done with the slides. Yes, we're done with the slides. Cool. So we are done. Do you have any questions so far? Can you please repeat? What exactly? Sorry, I messed up. Okay, so ectopic pregnancy pain, it could either be right lower quadrant pain, it could be left lower quadrant pain, it could be pelvic pain. Most probably they'll either bring right lower quadrant pain because they, you know, it's a mimicker of appendicitis, or they'll bring pelvic pain to make it very simple for you guys. So ectopic pregnancy, you want to look for a young female who has taken a pregnancy test, which was positive, BHCG was positive, which basically means pregnancy test. She's having nausea, vomiting, abdominal pain. That's ectopic pregnancy. Yes, we would use ultrasound for that. If we're suspecting appendicitis, it would be, again, a patient who hasn't eaten for a very long time, probably a male, could be a female, lower right lower quadrant pain, nausea, vomiting, can't eat. It's probably appendicitis, and you would go for CT with contrast. Now, usually you would go with CT with contrast, but in case they bring ectopic pregnancy, you should be aware of this. Yes, ovarian torsion for sure will be pelvic pain. They won't mess with you with ovarian torsion. For cholecystitis, we can use ultrasound. Yes, we usually use ultrasound for cholecystitis. How to differentiate between ectopic pregnancy and ovarian torsion? Ovarian torsion, ectopic pregnancy. So again, one, they will mention that there is going to be a pregnancy test, which is positive. If it's positive, you know it's a pregnancy. Ovarian torsion, if they bring an option of ultrasound with Doppler, that's probably ovarian torsion. Ovarian torsion, it may be an older female, like in her 50s or something. Ectopic pregnancy will always be a female, you know, young female, 20s, 30s, 40s, who can get pregnant. Ultrasound, pregnancy test may be negative in ovarian torsion. It's the other clues in the question, you know. What is the difference between diffusion weighted and flare? Okay, so diffusion weighted, it's only used for stroke and the area of infarct, acute stroke, and the area of infarct becomes bright. Okay, flare is basically T2, but the CSF is dark. That's the difference between them. Yes, ovarian torsion, use Doppler. Think of it in a logical way. What happens in torsion? Blood flow is stopped. So how do we detect blood flow is stopped? By a Doppler. Cool. You know what? Let me make your life a bit easier. Let me show you a picture of ovarian torsion so you don't have this. Ovarian torsion diagram. So much for diagram. Ovarian torsion cartoon. This is bad. Okay, let's use this. So basically you see this is the ovary and this is the blood vessel. So it basically flipped on itself, like twisted, twisted, twisted. And now blood flow can't flow out of it. Okay, so we use Doppler to be able to see if there's blood flow flowing out of it or not. Make sense? Okay, do you have any more questions? Was everything clear? Okay, so now firstly, thank you so much GND and MSA for making this possible, and I appreciate you guys a lot. Secondly, if you guys have any questions later on, you can always contact me. So you guys probably know my email or WhatsApp by now. If you don't, I'll write it down over here. I'll give you the extra slides as well in case you want them. I don't think they're needed because I don't want you to get confused, but sure, I'll do that. Yeah, I guess that's about it. 050-8528-261 if you guys want this. Yeah, and please give me feedback on this. Those of you who are going to watch later on YouTube, give me feedback on this. Was this better than the previous pre-midterm lectures or not? Did it help you in the exam or not? How useful was it? Would you like me to change something later on for the next batches? Inshallah, I give it for the next batches as well. But yeah, thank you so much. You are very welcome.